Let's go over the warm-up review. First question, where are the different types of collagen found in the body? So you might remember our mnemonic, a strong, slippery, stretchy BM for the 4 different types of collagen. Type 1 is the strong type, which is found in bones, tendons, skin, and the dentin of the teeth. Type 2 is your slippery type, found in cartilage, the vitreous body, and the nucleus pulposus. Type 3 is the stretchy type, found in blood vessels, in the uterus, fetal tissue, in the skin, and also granulation tissue. And then type 4 is BM for the basement membrane or the basal lamina. Then you can also remember SCAB for skin, cartilage, arteries, and basement membrane. That one's not as complete, but it's definitely shorter. All right, next. A 40-year-old man is brought to the ER following the sudden onset of a severe headache. He has a history of Ehlers-Danlos syndrome and hypertension. Examination of the CSF shows numerous red blood cells in the CSF. So what's the most likely cause of this man's headache? So this is a classic presentation for subarachnoid hemorrhage due to a ruptured berry aneurysm. Remember that the vascular type of Ehlers-Danlos syndrome is associated with berry aneurysms. The last one, how does the presentation of a dominant parietal lobe lesion differ from the presentation of a non-dominant parietal lobe lesion? The non-dominant parietal lobe is typically the right parietal lobe. The lesion there is going to cause hemispatial neglect, where the patient ignores or neglects the contralateral side of the world. And then a lesion in the dominant parietal lobe, which is typically the left parietal lobe, causes Gerstmann syndrome, agraphia, acalculia, finger agnosia, and left to right disorientation. Now let's go ahead and get started with the lecture.
Hello everyone and welcome to our Step 1 video on parasympathetic activation. Warning for this video, try to keep your mouth closed during the lecture. Not only will my Han Solo-esque rugged good looks cause your mouth to water, but the material itself will get you slobbering like a Pavlov dog in a bell factory. Don't worry, it'll make sense later. So today we're talking about the autonomic nervous system, and more specifically the pharmacology of parasympathetic activation. Now, in order to understand this, we have to take a brief step back and go over a little bit of the autonomic nervous system itself. Now, the autonomic nervous system is the part of the peripheral nervous system that helps to regulate many of our bodily functions, and luckily for us, it does this automatically. Now, where our somatic nerves are under voluntary control to flex our skeletal muscles, the autonomic nervous system is unconscious. Now, there are 2 opposing or maybe balancing forces in the autonomic nervous system. These are the sympathetic and the parasympathetic nervous systems. Now, you'll often hear the sympathetic nervous system associated with activities like fight or flight, and the parasympathetic nervous system associated with activities related to rest and digest. Now, we're going to concentrate on the parasympathetic nervous system really for the next 2 lectures. So where in the body is the parasympathetic nervous system? Well, let's think back to our cranial nerves. Cranial nerves 3, 7, 9, and 10 all carry parasympathetic nerve fibers. We also see parasympathetic nerve fibers come out of the 2nd and 3rd sacral spinal nerves as well. But having said that, about 75% of all parasympathetic nerve fibers are in the vagus nerve, so cranial nerve 10. Therefore, when we think about the parasympathetic nervous system, we will often be talking about the vagus nerve and its eventual innervations of a whole bunch of organs, like the heart, the lungs, the esophagus, the stomach, the small intestine, the proximal half of the colon, the liver, the gallbladder, the pancreas, the kidneys, and the upper portions of the ureters. Now, sometimes you'll just hear this referred to as vagal stimulation. Now, the autonomic nervous system sends out its messages to the organs by way of 2 different nerve fibers and a ganglion. So the first nerve fiber is called the preganglionic nerve, and it transmits its message to the ganglion. And I think of the ganglion as kind of like a relay station. Now, the message is then propagated to the second nerve fiber called the postganglionic nerve, and it ends at the effector organ. Now, the parasympathetic nervous system uses very long preganglionic nerves, and the postganglionic fibers are really pretty short, with the ganglia close to or even within the organ that it's innervating. Now, this is in contrast to the sympathetic nerves, which have relatively short preganglionic fibers and very, very long postganglionic fibers. So why is that important? Well, having these very long preganglionic fibers in the parasympathetic nervous system and very short postganglionic axons, it's really going to allow that parasympathetic nervous system to be more selective than the sympathetic nervous system. If you stimulate the sympathetic nervous system, you're kind of basically stimulating the whole system. It's very imprecise. In the parasympathetic nervous system, one postganglionic nerve is innervating one organ. Therefore, you can get a much more localized and precise stimulation. Now, the primary neurotransmitter of the parasympathetic nervous system is acetylcholine. The preganglionic neuron will secrete acetylcholine to stimulate nicotinic receptors at the ganglion. Now, the ganglion will then secrete acetylcholine again, which will stimulate muscarinic receptors on the effector organs. And this is important to know because many drugs exert what is referred to as muscarinic or anti-muscarinic effects. So now I want to briefly go over the difference between a nicotinic and a muscarinic receptor. These are the receptors that we'll see on the effector organs. Now, nicotinic receptors are ligand-gated sodium-potassium channels. Remember that we find these on our ganglia in the autonomic nervous system, but also be aware that the somatic nervous system uses nicotinic receptors at the neuromuscular junction as well. Now, muscarinic receptors are G-protein coupled receptors. They act through second messengers. Now, there are 5 subtypes, and they're named M1 through M5. Now, it's been said that the parasympathetic nervous system is associated with rest and digestion, but that's just a little too simplistic. Let's go through this by system. How does parasympathetic activation affect each organ? So what about the GI tract? Well, it's going to increase muscle motility and tone, so you're going to get more digestion, more transit through the intestines. What about the bladder? Well, you're going to get contraction of the wall, you're going to have relaxation of the sphincter. In the eye, you're going to get meiosis, and meiosis is constriction of the pupil. You're also going to get contraction of the ciliary muscles. That's going to lead to accommodation. In the lung, you're going to see smooth muscle contraction, so some bronchospasm. In the heart, you're going to get decreased heart rate and decreased contractility. In the lacrimal glands, you're going to get a stimulation of tear production. In the salivary glands, you're going to have watery secretion increased. In the penis, you're going to have an erection. In the clitoris, you're going to have an engorgement. Now, one way to remember excess cholinergic activation is with a mnemonic, dumbbells. This has been used for years. So DUMBBELSS. So it's not exactly spelled correctly, but it gets the point through. So let's go back to our list of parasympathetic activation, and now let's see what you get with too much stimulation. So you get diarrhea, you get urination, you get meiosis, you get bronchospasm, you get bradycardia, you get excitation of skeletal muscle and CNS. Now don't worry, we'll come back to that later. It doesn't fit our usual trend here. Lacrimation, salivation, and sweating, and we'll come back to that one as well. Now, one way I like to remember this is that everything becomes leaky. Extra fluid is going everywhere. Now, you'll notice that some blank areas in our parasympathetic list. Now, don't get confused. Cholinergic excess is not exactly the same thing as excess parasympathetic activation. A little confusing there, but we'll explain this. Cholinergic excess is another way of saying too much acetylcholine. So let me explain what I mean. Now, we just went through the parasympathetic actions, and I don't remember seeing anything about sweating or excitation of muscles. In fact, we should probably see relaxation of muscles in general with parasympathetic activation. So how do we get an excitation of skeletal muscle with too much acetylcholine? Well, what stimulates nicotinic receptors on skeletal muscle? Well, it's acetylcholine. So that's why you see muscle contractions or twitching with this organophosphate poisoning. Now, what about sweating? That one's a little bit more complicated. Sweating is controlled by the sympathetic nervous system, but it uses muscarinic receptors to stimulate that sweating. So remember that most of the time, the sympathetic nervous system likes to use alpha and beta receptors, which then respond to things like norepinephrine. But the sweat glands are different. The sweat glands are innervated with the muscarinic receptors. And what stimulates muscarinic receptors? Acetylcholine. And what do we have too much of in organophosphate poisoning? Acetylcholine. So that's how we get that extra E and S in our mnemonic. They aren't parasympathetic per se, but they are still stimulated by acetylcholine, and that's what's going on in this disease state. Now, if you're really smart, then you may argue, Dr. Lewis, the sympathetic nervous system uses acetylcholine to stimulate the ganglion. And I would say you're right. And you can see things like hypertension and even tachycardia with organophosphate poisoning. But acetylcholine will stimulate both the ganglion and the receptor in the parasympathetic nervous system. Therefore, you get a greater parasympathetic effect. And traditionally, test makers focus on the excess parasympathetic stimulation with organophosphate poisoning. Let's determine how organophosphates increase cholinergic activity. Well, organophosphates act by inhibiting acetylcholinesterase. And acetylcholinesterase is found in the synaptic cleft, and its job is to break down acetylcholine. Now, if you look at a synaptic cleft, you'll see a bunch of acetylcholine hanging out, and it stimulates muscarinic receptors. Now, acetylcholinesterase is also present, and it's breaking down acetylcholine, and it's breaking it down into choline and acetate. Now, if we don't have acetylcholinesterase, then we get way too much acetylcholine, and we get way too much stimulation of muscarinic receptors. So one way to counteract this is to competitively bind muscarinic receptors, to effectively block them. Now, what medication actually does this? Well, this is the mechanism of action of atropine, which is the primary antidote of organophosphate poisoning, atropine. Now, another treatment option for organophosphate poisoning is something called pralidoxime. So what does it do? Well, pralidoxime works by reactivating inhibited acetylcholinesterase. In general, pralidoxime is not given alone, but in conjunction with atropine. The highest yield stuff is the parasympathetic effects like bronchospasm, increased digestion, bradycardia, watery saliva, and stuff like that. Everything's getting leaky. So now we're going to cover some more specific drug categories. Now, there are two types of cholinergic agonists. And there are direct agonists and there are indirect agonists. Now, recall how we saw the neuron release acetylcholine into the postsynaptic cleft and bind to the muscarinic receptor. Well, the direct agonists are going to mimic the effects of acetylcholine. It's going to do exactly what acetylcholine wants to do. It's going to bind directly to the muscarinic receptor. So here are some examples. So the first one, bethanechol. And bethanechol is used in patients who get a postoperative ileus or urinary retention. Next, we have carbachol. It's used for glaucoma by causing pupillary contraction and will decrease intraocular pressure. Pilocarpine is a potent stimulator of sweat, tears, and saliva. Now, I actually had to use this on a patient of mine who had parotid gland cancer, and after treatment he had almost no saliva. His mouth was incredibly dry. So the pilocarpine was used to improve his symptoms, and unfortunately later on his saliva came back. Next, we have methacholine. It's been used historically as a challenge test to diagnose asthma because it causes bronchospasm. So next we have the indirect cholinergic agonists. So how do they work? Well, again, let's go back to our synaptic cleft. Remember that in the cleft there was those acetylcholinesterases, and its job was to break down that excess acetylcholine. Now, the indirect cholinergic agonists will inactivate that acetylcholinesterase and thus increase the amount of acetylcholine in the cleft, which leads to more stimulation of the muscarinic receptors. This should sound very familiar. This is exactly what we saw with organophosphate poisoning, but instead of poisoning people, we're giving them these medications to do a positive thing. So let's go through these. Neostigmine, that's used in post-op and neurogenic ileus and urinary retention. Kind of like just bethanechol. It's also used in the treatment of myasthenia gravis, and we'll talk about myasthenia in more detail in just a minute. It's also used to reverse the effects of neuromuscular blocking agents that are used in anesthesia. Next, we have pyridostigmine, and pyridostigmine is used for myasthenia gravis for long-term treatment. Again, we'll cover this in a little bit more detail in a minute. Next, we have edrophonium. Edrophonium is used in the diagnosis of myasthenia gravis because it's very short-acting. You might actually hear this referred to as the Tinselin test, but that's just the branded name for edrophonium. You probably don't have to memorize that. Next, we have physostigmine. Physostigmine is used for anticholinergic or atropine overdose. Next, we have ecothiopate. That's used for glaucoma. Donepezil is an Alzheimer's disease medication. We'll cover that in more detail right now. All right, so let's talk about Alzheimer's disease. So patients with Alzheimer's disease have reduced cerebral production of something called choline acetyltransferase, and that leads to a decrease of acetylcholine synthesis and impaired cortical cholinergic functioning. Therefore, to help this apparent lack of acetylcholine, we started using medications that inhibit the acetylcholinesterase and therefore increase the levels of acetylcholine in the brain. Now, the three that are FDA approved for Alzheimer's disease is donepezil, galantamine, and rivastigmine. Now, there's actually a new mnemonic that a student gave us to be helpful for Alzheimer's drugs, and it's Grandma Doesn't Remember, and that's to help you remember galantamine, donepezil, and rivastigmine. Now, at best, these medications provide a modest reduction in the rate of loss of cognitive functioning in Alzheimer's patients. Now, another indication that a patient has Alzheimer's is when you see amyloid deposits in the gray matter of the brain, and these are called senile plaques, so a good diagnostic thing there. So now, finally, let's briefly talk about myasthenia gravis. So what is myasthenia gravis? Well, it's a disorder with fluctuating weakness in the limbs, the eyelids, the extraocular muscles, and potentially respiratory muscles. Now, it's caused by antibodies to the acetylcholine receptor. Now on tests, you'll often see a question that describes a patient with worsening ptosis and diplopia that worsens throughout the day. Now you can diagnose this with that Tinslon test, that edrophonium test, which we went over. Again, that's just the brand name for edrophonium. Now this test can be very dramatic. If you ever get a chance to see it, it's really, really cool. I saw a patient that was almost completely paralyzed who was given edrophonium, and in a matter of seconds, she was moving and talking and was so thankful. It's one of those kind of treatments that looks like a miracle. However, a more specific test is testing for the autoantibodies against the acetylcholine receptor. It's not as cool as edrophonium, but if you get a question about which is a more specific test, then go with the autoantibody test. Now, what are some of the other things that you should know about myasthenia gravis? Well, it has some thymic associations. 50% is associated with thymic hyperplasia, 20% is associated with thymic atrophy, and 15% is associated with a thymic tumor, like a thymoma. Now, the most worrisome condition is a myasthenic crisis. And here we see rapid progressing weakness, especially in the respiratory muscles. Now, for treatment, we've already gone over the indirect cholinergic agonists like pyridostigmine and neostigmine. Remember that edrophonium is a very short-acting medication. It's only used for diagnosis, not for long-term treatment. Now, this is an autoimmune disorder, therefore you can use immunotherapy like corticosteroids, azathioprine, and cyclosporin. Now, interestingly, because there's some connection with the thymus, patients with generalized myasthenia gravis will have a thymectomy, and that can help symptoms as well. Now, the last thing you can do is plasmapheresis, which can be used to help filter out all those antibodies that are inhibiting the acetylcholine receptors. All right, so that's the end of the lecture part. It's time for the end of session quiz. Try to answer those questions on your own, and then we'll go through the answers together. First question, how does parasympathetic nervous system affect the following body structures? So we went through this once, let's go through it again. The heart, you're going to get decreased heart rate, maybe a small decrease in contractility. In the eye, you're going to see meiosis, you're going to see contraction of the ciliary muscle. In the salivary gland, you're going to get increased saliva production and secretion. In the lung, for that bronchiolar smooth muscle, you're going to get contraction. For the bladder, you're going to get contraction of the bladder wall and relaxation of the sphincter. And the male GU, you're going to get an erection. And then on the GI tract, you're going to have contraction of the intestinal wall, relaxation of the sphincter, overall increase in transit. Next, what drug regenerates acetylcholinesterases after organophosphate poisoning? Remember, the drug there is going to be pralidoxine. Next, what is the antidote for organophosphate poisoning? Well, the antidote is actually atropine. Remember, we just talked about pralidoxine that can be used to help regenerate that acetylcholinesterase activity in the synaptic cleft, but the actual antidote is atropine. Next, which anticholinesterases are used in the treatment of Alzheimer's disease? So remember, it's going to be donepezil, galantamine, and rivastigmine. All right, and then finally we have just a couple rapid fire facts. Amyloid deposits in gray matter of the brain, that's going to be those senile plaques that we see in Alzheimer's disease. And then the drooling farmer, always think of organophosphate poisoning. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's take a look at the warm-up review. First question, anxiety is associated with altered levels of which neurotransmitters? So in anxiety, there tends to be decreased GABA, increased norepinephrine, and decreased serotonin. Next, a patient's uvula deviates to the right when she says ah. So damage to what neurological areas would produce this abnormality? So rightward deviation of the uvula means that the muscles of the right palate are raising the palate, but the muscles of the left palate are not. So you can see rightward deviation of the uvula with damage to the left vagus nerve, cranial nerve 10, and the left nucleus ambiguus. But then above the nucleus ambiguus, the right motor cortex controls the uvula by sending signals to the nucleus ambiguus via the right corticobulbar tract. But the nucleus ambiguus receives projections from both sides of the cortex, both left and right cortex. So a lesion above the nucleus ambiguus won't necessarily cause the uvula to deviate. The last one, what prenatal testing is abnormal in a fetus with a neural tube defect? So alpha-fetoprotein can be elevated in the maternal serum and also the amniotic fluid. Acetylcholinesterase can be elevated in the amniotic fluid, and then a sonogram may show the defect. All right, let's move on to the lecture.
Hello everyone and welcome to another Step 1 lecture. Students, I've been teaching in front of the camera for some time now, and though it's a little embarrassing, I do have a fan or two. Now many of them say to me, Dr. Lewis, you should really be an actor, get up on the big screen and become famous. But I tell them, I'm dedicated to teaching now. And anyway, I've been down that path before. Remember a little movie called, I don't know, Star Wars? Yeah, who do you think played Darth Vader? Yep. And oh, what was the name of that film, 2001: A Space Odyssey? You remember a certain supercomputer named HAL?
I'm sorry, Dave.
And then, who could forget that groundbreaking comedy, The Cosby Show? Who was that who played the adorable but hilarious role of Rudy Huxtable?
Rudy!
I don't like to name names. So students, I appreciate all that feedback, but as you can see, I've already lived the life of a Hollywood superstar. Now, it's time to make you some superstars. All right, so in our last lecture, we went over what happens when you stimulate the parasympathetic nervous system. We also talked about a few drugs that we use clinically. Now we need to focus on inhibiting the parasympathetic nervous system. And though it doesn't seem that complicated, students do get a bit tripped up here. We've said previously that the autonomic nervous system is a balance between sympathetic and parasympathetic. But inhibiting the parasympathetic nervous system is not the same thing as stimulating the sympathetic nervous system. There is a difference between the two. Now, in the last lecture, we filled out a table that listed the effects of stimulating the parasympathetic nervous system. Let's review that very quickly so we can predict what happens when we inhibit that stimulation. So remember, in the lung, we saw that smooth muscle contraction, so that led to bronchospasm. In the GI tract, we had increased muscle motility and tone, so you got more digestion and transit through the intestines. Those salivary glands are going to make that copious watery secretion. In the heart, you're going to have a decreased heart rate, decreased contractility slightly. In the eye, you're going to get miosis, that's constriction of the pupil, contraction of the ciliary muscle, which leads to accommodation. In the lacrimal glands, you're going to see stimulation of tear production. In the bladder, you're going to see contraction of the wall and relaxation of the sphincter. In the penis, you're going to see erection, and in the clitoris, you see engorgement. So let's go ahead and look in the study guide here. What are the symptoms of inhibiting the parasympathetic activity? Now, also, instead of saying parasympathetic inhibition, a question might ask you about anticholinergic or antimuscarinic effects. And that's going to make sense because, as we went over in the last lecture, the parasympathetic nervous system uses acetylcholine as its major neurotransmitter and muscarinic receptors. Those are going to be located on the effector organs. So if we're blocking the effects of acetylcholine, then we refer to this as anticholinergic. If something is antimuscarinic, then it's not necessarily anticholinergic. It's simply blocking the muscarinic receptors and perhaps not affecting acetylcholine at all. However, when referring to the symptoms of inhibiting all three of these things, then the answer is going to be the same. Though technically not the same, antimuscarinic and anticholinergic are often used pretty interchangeably. Now, in the real world, we use the term anticholinergic effects a lot more often than we use antimuscarinic or parasympathetic inhibition. So what's the answer to this question? Well, recall that stimulating the parasympathetic nervous system caused everything to become very leaky. Remember old MacDonald, he started to drool because of all that organophosphate poisoning. Well, if we inhibit the parasympathetic nervous system, then we dry everything up. Now, many of you might be using the common memory tool hot as a hare, red as a beet, blind as a bat, dry as a bone, mad as a hatter, and bloated as a toad. Let's go through those together. So first we have hot as a hare. That's referring to the hyperpyrexia that can take place. Now, because you're not sweating as much. Now, this can be a little bit confusing because sweating is actually mostly controlled by the sympathetic nervous system, but the sweat glands are innervated with those muscarinic receptors. So that's why you see this occurring with anticholinergic activity. People will have the flushing, which will account for red as a beet. Next, we have blind as a bat. That's going to occur because blocking the parasympathetic activity will cause psychoplegia and mydriasis. Therefore, patients will lose the ability to accommodate. Patients will be dry as a bone because they won't be salivating as much. They're also going to be mad as a hatter. Acetylcholine is an important neurotransmitter in the brain as well as in the periphery. Therefore, you can see things like delirium when you inhibit it. Bloated as a toad is referring to constipation and urinary retention. And then another symptom that we see that maybe hasn't been used in the memory tool in the past is tacky as a polyester suit. And this is going to help you to remember tachycardia. So the vagus nerve, which is the major parasympathetic nerve in the body, helps to slow down the heart. Therefore, if you inhibit this, then you might get tachycardia. So let's move on to our muscarinic antagonists. So what drugs inhibit our parasympathetic activity? What are their uses? Now, the prototypical muscarinic antagonist is atropine. So atropine will have many of the effects that we just described. Now, clinically, it's used to treat bradycardia. In the past, it was also used to dilate the pupil. It's not used so much anymore because we have newer drugs that don't last as long. People generally don't want to be dilated all day. Now, we mentioned in our last lecture that atropine is still used to treat organophosphate poisoning. So what was that other medication that we used to treat organophosphate poisoning? Remember, it was pralidoxime. Pralidoxime acts to regenerate acetylcholinesterase, which will normally break down all the excess acetylcholine in the synaptic cleft. Now, atropine was also previously used for enuresis in children, but again, we have better drugs for that now. So atropine had a lot of uses in the past. Now let's talk about some other anti-muscarinic drugs, including things like homatropine, tropicamide, and cyclopentolate. So these are used topically to dilate the pupil. They have a much shorter duration than atropine, therefore they are used a lot more often nowadays. Next, we have benztropine. This is used to help treat Parkinson's disease and also to help reduce the side effects of antipsychotic medication. Glycopyrrolate, so this is used in anesthesia to help reduce salivary, tracheobronchial, and pharyngeal secretions. It can also be used to help decrease gastric acid production. Hyoscyamine and dicyclamine, so these are antispasmodics that are used for irritable bowel syndrome. So this will help with decreasing the painful cramping associated with IBS, irritable bowel. Scopolamine. Scopolamine is used in patch form that actually you put behind your ear, and its help is mainly with motion sickness. It's also helpful to decrease oral secretions, again, which can be used with patients who are mechanically ventilated over a long period of time, so especially with patients who can't clear their secretions very well, those that maybe have had strokes. Next, we have ipratropium and tiotropium. So these are actually inhaled drugs that can be used in asthma and COPD. They help decrease bronchoconstriction and can help open up the airways. Oxybutynin is used to decrease overactive bladder symptoms. And this brings us to another study guide question. What anticholinergics are used in the treatment of urge-type urinary incontinence? So it's not just oxybutynin, it's other ones. There's actually a nice mnemonic that you can use for urinary incontinence. It's off the darn toilet seat. So the O is oxybutynin, the T is tolterodine, the D is for darafenicin, the T is for atrospium, and the S is for seat is going to be for solifenacin. All right, so since pharmacology is such a tough part of step one, let's go over what we just learned in a Lewis Notes. Hello everyone and welcome to another Lewis Notes, and we're looking at our muscarinic antagonists. So we've got our list of drugs on the left. You might want to write those down. And then we've got their uses over here on the right. And this is just another exercise again to get this stuck in our brain. So the first one we have here is atropine. Atropine has a lot of uses, maybe not quite as practical as it used to be back in the past, but we still definitely use it for organophosphate poisoning. So let's grab that one and put that one over there. Next, we have benztropine. Benztropine can be used in the Parkinson's disease, and that can be used right there. And then it can also be used to treat some of the side effects with the antipsychotic drugs. Next, we have scopolamine. So scopolamine is used, especially if you're going to go on maybe a sea cruise or something. You're going to go fishing and you get seasickness or motion sickness, and you're going to use that there. Ipratropium bromide, used pretty often as a bronchodilator, especially in our COPD patients. You can use it in asthma as well. Oxybutynin is one of our drugs that we use for some overactive bladder. So if you have urge incontinence, then you can use oxybutynin for that one. Tropicamide, you're going to use this in your ophthalmologist's office to dilate that eye to be able to get that exam done right. Darafenicin is another one of those urge incontinent drugs that can be used overactive bladder, that type of stuff. Tiotropium, very similar to ipratropium, is a bronchodilator again. We're going to use that. It's a little bit longer acting than ipratropium. Next, we have the glycopyrrolate. Glycopyrrolate is going to be used to decrease airway secretion, so use in anesthesia more often to help decrease all the goo that's going to come out. All right, so just another review there for some of our muscarinic antagonists. All right, so let's move on. Moving on in the study guide, in what patient populations is atropine contraindicated? So several things here. Well, first we have patients with BPH, benign prostatic hyperplasia. These patients tend to have problems with urinary retention, so we don't want to make that worse by giving them atropine. Because antimuscarinics can cause hyperpyrexia, you wouldn't want to use this in a patient with hyperthermia. A big one that you might be tested on is that you never want to give atropine to a patient with acute angle glaucoma. Recall that atropine and all this anti-parasympathetic activity can cause cycloplegia and mydriasis, and this can actually result in an increase in intraocular pressure. You also need to be careful when using atropine in the elderly. Atropine can cause delirium. In fact, even less potent medications that we'll talk about in a little bit that have anticholinergic effects like antihistamines even can lead to things like delirium in the elderly. And finally, you want to avoid using atropine in patients with GI obstruction or ileus because again, that can make it worse. All right, so now let's move on to some other drugs that still have some anticholinergic side effects. We don't necessarily call them anticholinergics, but they still have that effect. So those are, again, the major contraindications, as we said before, of atropine. But let's look again in the study guide. What medications have anticholinergic side effects? The first generation H1 blockers are the first one I want you to think about. Diphenhydramine, doxylamine, and chlorpheniramine. So commonly used stuff that's even over the counter. Neuroleptics, especially thyroidazine, chlorpromazine, clozapine, olanzapine. And then also thinking about the tricyclic antidepressants. And then finally, amantadine. We don't use that quite as much as we used to, but that can also have some major anticholinergic, antimuscarinic effects. Now, test makers love to make questions where an elderly patient presents in acute delirium, and you need to be on the lookout for drugs with anticholinergic effects. Now, an example would be an elderly patient maybe just started taking diphenhydramine for some allergy symptoms and then started acting kind of goofy. All right, guys, that brings us to the end of our lecture part. Now it's time for the end of session quiz. I want you to pause that video, try to answer those questions on your own, and then we'll go through them together. First question here, identify the following drugs as direct muscarinic agonists, anticholinesterases, muscarinic antagonists, or a cholinesterase regenerator. So knowing these different drugs is incredibly important for your step 1 or level 1 exam. Some of these that we're going to go through were covered in the last lecture, so this is a big one. First one is physostigmine. This is going to be an anticholinesterase. Pilocarpine, that's going to be a direct muscarinic agonist. Next, we have oxybutynin. That's going to be a muscarinic antagonist, and we use that in urge incontinence. Next, we have atropine. That's going to be a muscarinic antagonist. Donepezil, that's going to be an anticholinesterase. Pralidoxime, that's the one unique one. That's our cholinesterase regenerator. Remember, we use that one for organophosphate poisoning. Bethanechol, that's going to be a muscarinic agonist. Neostigmine is an anticholinesterase. Darafenicin is a muscarinic antagonist. Ipratropium is a muscarinic antagonist. Tropicamide is a muscarinic antagonist. And benztropine, that's going to be another muscarinic antagonist. Scopolamine, same thing, muscarinic antagonist. Edrophonium, finally, we have an anticholinesterase. Tolterodine, that's going to be a muscarinic antagonist. That's going to be used for urge incontinence. Trospium is a muscarinic antagonist, again, urge incontinence. Rivastigmine is an anticholinesterase. We use that one for Alzheimer's disease. Homatropine, that's going to be a muscarinic antagonist, very similar to atropine. Pyridostigmine is an anticholinesterase. And then carbachol is a muscarinic agonist. All right, last question here. Which of the muscarinic antagonists discussed could be used to improve FEV1 in a patient with COPD? So remember, ipratropium and tiotropium. All right, guys, that's it for the video. I hope you learned something. I'll see you next time.
Let's go through the warm-up review. First question. A patient cannot adduct her left eye on lateral gaze, but convergence is normal. So which structure is damaged? Well, this is describing internuclear ophthalmoplegia. So the damaged structure would be the medial longitudinal fasciculus, specifically the left MLF in this case. Next, a 2-year-old child who's had multiple viral and fungal infections is found to be hypocalcemic. Which of the 3 germ layers gives rise to the structure that's missing in this child? So this is one of those 2-step questions. First, you have to recognize that this patient has DeGeorge syndrome. Then you have to know that DeGeorge syndrome is caused by failure of the pharyngeal pouches to develop, and that the pharyngeal pouches are derived from endoderm. So the answer here is endoderm. And the last one, describe the sensory innervation of the tongue. So the anterior 2/3 of the tongue are innervated by the facial nerve and the mandibular division of the trigeminal nerve. So the facial nerve is the taste sensation, and the other sensation is provided by the trigeminal nerve. And then the posterior third of the tongue is innervated by the glossopharyngeal nerve and the vagus nerve. The vagus nerve innervates the most posterior section of the tongue. All right, let's get started with the lecture.
Hello everyone and welcome to our Step 1 video on sympathetic activation. Now, if you think this subject is about improving your ability to project sympathy or maybe kindness into an uncaring world, then you are out of luck. We will not be petting baby kittens, nor will there be any group hugs. The only hugs you'll likely see is you clutching your chest due to the severe tachycardia from a sudden increase in beta-1 activity caused by the sudden norepinephrine release due to the panic attack that you should be having right now because you don't know this material. I'm just kidding. This stuff's pretty easy. Look, a pretty kitty. Feel better now? All right, let's get going. So this lecture is going to cover sympathetic activation. In previous lectures, we covered parasympathetic activation and inhibition as well. So now we're going to cover the other side of the autonomic nervous system. Now recall when we spoke about the parasympathetic nervous system, we had a very long preganglionic neuron that ended at the ganglion very close to the effector organ. Acetylcholine would stimulate the nicotinic receptor at the ganglion, and then again acetylcholine would stimulate the muscarinic receptor on the effector organ. Well, this changes considerably in the sympathetic nervous system. The preganglionic neuron is very, very short this time, and the ganglion is going to be near the spinal cord, not close to the effector organ at all. Those post-ganglionic fibers are going to be very, very long, and they're going to branch multiple times, thereby innervating more than one organ system. Now again, the sympathetic nervous system uses acetylcholine to stimulate the nicotinic receptor on the ganglion, but then uses norepinephrine to stimulate adrenergic receptors on the effector organs. So why is this so important? Well, there can be tighter one neuron to one organ control in the parasympathetic nervous system. And again, that's due to those really long preganglionic fibers going all the way to the effector organs. You don't have that kind of control in the sympathetic nervous system. All those postganglionic fibers are branching all over the place. Therefore, when the sympathetic nervous system is stimulated, then you're really just tending to stimulate a lot of things all at once. So next, let's talk about the adrenergic receptors. This is the important part of this lecture. The four that you really need to know the most for step one are going to be alpha 1, alpha 2, beta 1, and beta 2. Now, when alpha 1 receptors are stimulated, this results in vascular smooth muscle contraction. So what is this going to do? Well, it's going to lead to increased peripheral resistance. It's going to give you some increased blood pressure. In the eye, it's going to act with mydriasis. And then also you're going to see some increased bladder sphincter muscle contraction. Next, let's talk about the alpha 2 receptors. Those are a bit different. You only find alpha 2 receptors on just actually a few organs, things like the beta cells of the pancreas and on certain smooth muscle cells. Now, the most important location of the alpha 2 receptor, though, is on the presynaptic nerve itself. And when stimulated, the alpha 2 receptor acts to inhibit norepinephrine release. So let's go through an example. So you have a sympathetic nerve fiber, and it's been stimulated to release norepinephrine. Some of that norepinephrine is going to circle back and then bind to the alpha 2 receptor on that same neuron. And what is it going to do? It's going to cause inhibition of further norepinephrine release. So this is actually a negative feedback mechanism. And then also because they're present on the pancreas, it kind of acts to inhibit insulin release. Next, we have the beta 1 receptors, and when they're stimulated, you're going to see things like tachycardia, increased lipolysis, increased myocardial contraction, and increased release of renin. And as you can tell, there's probably going to be a lot of beta 1 receptors on the heart. And then finally, we have the beta 2 receptor. So that's going to cause vasodilation, which will lead to maybe just a slight decrease in peripheral resistance. More importantly, it's going to cause bronchodilation. You're also going to see increased lipolysis, increased insulin release, and decreased uterine tone, another important one. You also generally see an increase in heart rate, but this is not because of direct stimulation of the heart like with our beta 1 receptors. Here, the heart rate is increasing because of a compensatory response due to that drop in blood pressure from that vasodilation. Now, adrenergically innervated organs tend to have a predominance of one type of receptor. For example, tissues such as the vasculature to skeletal muscle have both alpha 1 and beta 2 receptors, but the beta 2 are probably going to predominate. The heart, as we said before, contains a lot of beta 1 receptors, and then the lungs have a whole lot of beta 2 receptors. Okay, so let's pound this into your brain one more time. You have to know this stuff, Pat. Nothing else in this lecture is going to make sense unless we go through this again. So let's do another Lewis notes. All right, welcome to another Lewis Notes, guys. We're doing another matching game, and we're looking at our adrenergic receptors, and we're going to combine our results here when we're stimulating these receptors. What are you going to get? So the first one we have here is heart rate, and we're increasing our heart rate, remember, with our beta 1. It's always going to be beta 1 because those are really on the heart. Next, we have decreasing uterine tone. Sometimes people forget this one, but this is actually going over here with beta 2. Next, we have increasing blood pressure. I'm putting this over here with alpha 1. It would probably also be with beta 1 as well, but alpha 1, you think of that peripheral resistance going up. Inhibiting norepinephrine, remember, this is very unique to alpha 2. That's actually how it's going to work to decrease blood pressure to some extent. Increasing heart contractility. So what's on the heart? Remember, on our heart is our beta 1s primarily. Mydriasis, this is another one that's a little bit trickier to remember, but remember, mydriasis is going to go with our alpha 1. Increased bladder sphincter tone, again, alpha 1. And remember, our alpha blockers are going to be going after those. Vasodilation. So vasodilation, it's not dramatic, but you are going to get a little vasodilation with beta 2. Increasing renin, that's going to go with beta 1. Bronchodilation, very important one, probably the most important one to remember is going to be with beta 2 again. And then increasing peripheral resistance, that's going to go along with our alpha 1 over here, and that's why you're going to increase the blood pressure with that. All right, guys, so that's going to be it for our Lewis Notes. So next, let's talk about the sympathomimetic. So a sympathomimetic is a drug that stimulates the sympathetic nervous system. However, the effect that each drug exerts is going to depend on which receptor it's going to stimulate. Now, since we just learned our receptors, we should be in good shape concerning these drugs. First, we'll cover the direct sympathomimetics. Now, the direct agonists or sympathomimetics bind to adrenergic receptors without interacting with the presynaptic neuron. That'll make more sense when we talk about the indirect. So the first drug we're going to talk about is epinephrine. So epinephrine stimulates all of the major adrenergic receptors that we just mentioned. So it's going to stimulate alpha 1, alpha 2, beta 1, and beta 2. Now, what are we going to use it for? Well, we use epinephrine for anaphylaxis. So if a patient is severely allergic to peanuts or bee stings, he or she may carry around an EpiPen, which is a syringe that a patient can carry around and then self-administer if they're having a big reaction. Now, it can be inhaled in certain respiratory problems like severe croup. Epi can also be used in hypotension. And that makes sense because the alpha 1 will vasoconstrict and the beta 1 will increase the heart rate. Next, we have norepinephrine. So here we see a strong alpha 1 and alpha 2 stimulation, also moderate beta 1 stimulation, and basically no beta 2. Now, norepinephrine can also be used for hypotension because it has such strong alpha 1 stimulation, it's going to decrease renal perfusion due to that vasoconstriction. Norepinephrine is usually first line for septic shock. And why would we want to do that? Well, in septic shock, you have a lot of vasodilation in blood vessels. But it can also be used for cardiogenic shock as well. Next, we have isoproterenol. This one only works on beta 1 and beta 2, and clinically it's really not used that much, so I wouldn't put too much of your memory into that one. Next, we have dopamine. So dopamine is a weird one. At very low doses, dopamine will stimulate dopamine receptors. Now, we haven't talked about dopamine receptors yet. Now, most of the time we think about dopamine receptors as being in the CNS, being associated with things like schizophrenia, Parkinson's disease. But we also have dopamine receptors in the blood vessels and in the kidney. Now, at medium doses, we see a change here. We see stimulation of beta 1 and beta 2. And at very high doses, you're actually going to start stimulating alpha 1 and alpha 2. So dopamine can be used in shock. It was thought that the stimulation of those dopamine receptors actually helped with renal perfusion, but studies now have shown that dopamine when used in shock actually doesn't improve renal function at all, so don't remember that one anymore for renal problems. Next, we have dobutamine. So this works primarily at beta 1 receptors. Now, dobutamine increases heart rate and that contractility. Now, you may see in some places that it won't increase heart rate, but it actually will. Now, we use this in stress tests. So some people actually have a hard time walking on a treadmill to get their heart rate up. So you can actually give them something like dobutamine, and that's going to stress their heart. You can also use this in heart failure as well. Next, we have phenylephrine. So phenylephrine causes strong alpha 1 stimulation. This is used for pupillary dilation, very commonly used as a nasal decongestant. Next, we're getting into some inhaled products, so albuterol, levalbuterol, salmeterol. So these have strong beta 2 stimulation, maybe just a little bit of beta 1 as well. So these are used mostly as inhaled drugs for asthma. Now, because of their beta 2 stimulation, they cause bronchodilation. That's exactly what you want. Now, because of that slight beta 1 activity, patients will often get some tachycardia, though this is less pronounced in levalbuterol. Next, we have terbutaline. This also has a strong beta-2, also has some beta-1 as well. Now, it can be used for bronchospasm, but you'll also see this being used as a tocolytic agent, so tocolysis. So that's going to hopefully inhibit uterine contractions in preterm labor. So there are beta-2 receptors on the uterus, which when stimulated will decrease uterine tone. Now, terbutaline can also be given sub-Q, which is great for very immediate action. And next we have a very interesting drug, clonidine. So clonidine is an alpha-2 agonist. Well, what happens if you only stimulate that alpha-2? So that's kind of our weird adrenergic receptor. Remember that alpha-2 is going to decrease the secretion of norepinephrine from the presynaptic neuron. So alpha-2 is that negative feedback mechanism receptor on that presynaptic neuron. So this medication can be used to decrease blood pressure. You have less norepinephrine around. So you have to be careful though with clonidine, because when you stop it abruptly, you can actually see significant rebound hypertension. All right, so now let's switch gears. We're going to move over to the indirect sympathomimetics. And now the indirect agonists cause catecholamine release from the presynaptic terminal, or their other mechanism is that they can inhibit the reuptake of catecholamine. So those catecholamines are going to stick around longer in the synaptic cleft. So these meds aren't interacting with the receptors on the effector organs like what we just saw with our direct agonists. They are just increasing the released norepinephrine and dopamine, and then those neurotransmitters will then bind to the receptors more, causing a lot more of the stimulation that we want to see. So what are examples of this? So the first ones are the amphetamines. So they work by releasing stored catecholamines. So you're getting more catecholamines out. So this can be a recreational drug. It's methamphetamines, it's speed. But in medicine, we can also use it for narcolepsy. You can also use it for obesity because it decreases appetite, and for attention deficit disorder. So again, remember that the amphetamines increase the release of the stored catecholamines, so you have more in that cleft. Next, we have ephedrine. Again, this is going to increase the released stored catecholamines, very commonly used in oral and nasal decongestants. It's also used in urinary incontinence as well. And finally, good old-fashioned cocaine. So this works a little bit differently. This is our second mechanism of action. So it's actually inhibiting the reuptake of the catecholamines. So the release is normal, but because there's less reuptake, there's more norepinephrine, more dopamine potentially in the synaptic cleft, and thus more stimulation of the adrenergic receptors. Now this does have some medical use. The ear, nose, and throat doctors will use this as a nasal decongestant and as a local anesthetic as well. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. So try to pause that video, try to answer the questions on your own, and then we'll answer them together. All right, first question. Which receptors are stimulated by the following sympathomimetics? So we're going to go through a big long list here again. So first we have clonidine. Remember that was our weird one that's going to only go after your alpha-2 receptors. Next, we have dopamine. That's going to stimulate the D1 and D2 at very low doses. Remember, at that medium dose, you're going to get beta-1 and beta-2. And then at the high doses, you're going to get the alpha-1 and alpha-2. Next, we have phenylephrine. That's going to be doing a little bit more alpha-1 than alpha-2. And remember, that's that vasoconstricting drug. Next, we have albuterol. Albuterol is going to do a lot of beta-2 activity, but you're also going to get a little beta-1 as well. Norepinephrine, this is where it gets a little bit tricky, does alpha-1, alpha-2, and beta-1. It's basically just like epinephrine, except for you're probably dropping a little bit of the beta-2. Next, we have isoproterenol. That's going to be beta-1, beta-2 equally. Epinephrine is going to be alpha-1, alpha-2, beta-1, and beta-2. So it's doing the whole thing. Dobutamine is going to be beta-1 more than beta-2 and not very much alpha at all. And then terbutaline is going to be a lot of beta-2 and a little bit of beta-1 and none of the alphas. Next question. Which sympathomimetic matches the following statement? So first we have given as a nebulizer for asthma. So this is probably going to be albuterol or maybe levalbuterol. You could potentially put epinephrine here, but that's not first line. The first line med for acute asthma is going to be something like albuterol or levalbuterol. Next, we have drug of choice for anaphylaxis. That's going to be that EpiPen, so epinephrine is going to be the best for that. Next, we have most common first-line agent for patients in septic shock. So you think about norepinephrine is going to cause a lot of peripheral constriction. Next, we have given sub-Q for asthma, not done very often, by the way, but that's going to be terbutaline. Next, we have used as ENT to vasoconstrict nasal vessels. Could be either phenylephrine, or occasionally you'll find a doctor who still has cocaine in their office, and they can use it in that situation as well. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's go over the warm-up review. First question, which structures are derived from the pharyngeal pouches? So the first pharyngeal pouch is where we get the mastoid air cells in the middle ear cavity and also the eustachian tubes. The second pouch is the lining of the palatine tonsil. The third pouch is the thymus and the inferior parathyroid glands. And then the fourth pouch is the superior parathyroids. Next, which structures run through the cavernous sinus? So you have the oculomotor nerve, which is cranial nerve 3, the trochlear nerve, which is cranial nerve 4, the abducens nerve, or cranial nerve 6, the ophthalmic nerve, which is the first division of the trigeminal nerve, cranial nerve 5, the maxillary nerve, which is the second division of cranial nerve 5, and then also the internal carotid artery. Last question, what are the clinical features of osteogenesis imperfecta? So you're going to see brittle bones and multiple fractures, blue sclerae, dental problems, and possibly hearing loss. All right, let's move on to the lecture.
You know, there's nothing really funny about beta blockers. Hello everyone and welcome to our Step 1 video on sympathetic inhibition. Let's get going. Okay, so in our last lecture we talked about sympathetic activation. Let's do a super rapid review. So in sympathetic nervous system we have short preganglionic fibers stimulating nicotinic receptors on ganglions that are very close to the spine, and then very long postganglionic fibers that secrete norepinephrine that are going to stimulate those adrenergic receptors, and that's going to be right on those effector organs. Now we had 4 very important adrenergic receptors. Remember those? It was alpha 1, alpha 2, beta 1, and beta 2. Now remember that alpha 1 caused an increase in peripheral resistance and increased bladder sphincter tone. Alpha 2 inhibited norepinephrine released on the presynaptic neuron. Remember, it's causing that negative feedback back on itself. And then beta 1 increased heart rate and contractility. Beta 2 caused mild vasodilation, and then more importantly, bronchodilation. Now the drugs we talked about varied depending on their effect on each one of those receptors that are found in the different concentrations throughout the body. So now we're going to inhibit the sympathetic nervous system, and just like the mimetic drugs, these drugs will act depending on their effect on the specific adrenergic receptors, and we even refer to them as such. So there are alpha blockers and there's beta blockers, and a couple of others that really don't exactly fit into those categories. So first let's talk about the alpha blockers. Remember that alpha 1 receptors maintain our vascular resistance, and then they also act on the urinary sphincter bladder tone. So if you block them, we should expect to decrease our blood pressure and then also relax the bladder sphincter tone. Now alpha 2 receptors tend to decrease norepinephrine release, as we mentioned before, that negative feedback, and the alpha blockers are divided into drugs that are non-selective, meaning they block both the alpha 1 and the alpha 2 receptors, and then there's also the selective agents that only block alpha 1. Now, the more commonly used medications are the selective blockers, and they include things like prazosin, doxazosin, and terazosin. Now, since they block alpha 1, they tend to decrease blood pressure. Now, clinically, though, they're probably used more often for their effect on that bladder sphincter relaxation. Now, specifically, they're used in men with benign prostatic hyperplasia, or BPH. Now, their side effects include postural hypotension. So when they stand up, they kind of drop their BP real quick and they can pass out. And that certainly makes sense because these drugs, again, will reduce peripheral resistance. Now, also you'll see some reflex tachycardia, and again, that makes sense again because your body senses a lower peripheral resistance. It's going to tend to react by increasing that heart rate to compensate. Rebound hypertension is also a concern when you stop these medications abruptly. Now there's one other alpha-1 selective drug that I want to touch on, and it's tamsulosin. Tamsulosin is an alpha-1 antagonist used to treat BPH by inhibiting smooth muscle contraction, so nothing different there. So just like your Zosyn drugs. But this one is selective for something more specific. It's called the alpha-1AD receptor, and these are found primarily just in the prostate. So it relaxes that smooth muscle in the prostate region, that urethral smooth muscle, so that urine can pass more easily. It does not relax the vascular, what we call the 1B receptors as much. So tamsulosin is not going to lower your blood pressure as much as those other kind of typical alpha-1 blockers. So patients with BPH and high blood pressure maybe go with one of those Zosyn drugs, those first drugs we talked about. If they don't have high blood pressure, then maybe stick with tamsulosin so it doesn't affect them as much. Now, the non-selective alpha blockers are not used clinically that often. The examples of these are going to be phenoxybenzamine and phentolamine, and they're used in the diagnosis and temporary treatment of pheochromocytoma. Now, since we don't see that very often, we don't have much use for these drugs on our day-to-day basis. Now, one of the reasons we use phenoxybenzamine is because it irreversibly binds to the alpha-1 receptor, and even very high levels of catecholamines, like what we do see in that pheochromocytoma, they're unable to stimulate those alpha receptors at all. So the next class of sympathetic inhibitors are our beta blockers. We use these all of the time. And again, we have a few subgroups depending on which receptors they're inhibiting. First, we have the non-selective beta blockers, which are, as you can probably guess, blocking both beta 1 and beta 2 receptors. And these include drugs like propranolol, timolol, and nadolol. And then we have our cardioselective, or what are also referred to as the beta-1 selective blockers, and they include metoprolol, atenolol, and esmolol. And as the name implies, they're just going after the heart. They're just doing beta-1. And there actually aren't very many clinically usable beta-2 selective blockers. There's just no reason to have those. Now, there are two unusual beta blockers. They're called acebutolol and pindolol. They are actually very weak agonists. They're not technically blockers at the beta 1 and the beta 2, but because they are so weak, clinically they actually act as blockers because they're blocking the much more potent effect that norepinephrine or epinephrine would have on those same receptors. So it's just kind of getting in the way. Now, you would consider using these in patients with hypertension that maybe also have problems with bradycardia. So these don't actually cause much of a decrease in heart rate. Now, there's another unusual beta blocker named nebivolol. So nebivolol is a selective beta-1 blocker, which isn't all that exciting, but it also stimulates endothelium-derived nitric oxide-dependent vasodilation. So for nebivolol, remember beta-1 blocking, and then you're also getting this nitric oxide action, and it's causing vasodilation in the periphery. And then finally, we have another kind of weird one, hybrid alpha-beta blockers. These include things like carvedilol and labetalol. They block at alpha-1 and beta-1, so you get the regular beta blocker effect, but you also get that really nice peripheral vasodilation as well. Now, beta blockers are used quite often to treat hypertension. Also, by blocking beta-1 receptors, you slow the heart and decrease contractility, and thus decrease the overall work of the heart, which is highly favorable with patients with coronary artery disease. So you'll see these drugs used in patients with angina, hypertension, and in patients after a myocardial infarction. Now, beta blockers can slow the progression of congestive heart failure, but you must also be careful in patients in a CHF exacerbation. So in an exacerbation, that poor contractility might lead to fluid retention, even pulmonary edema, a lot of shortness of breath. Using a beta blocker in this situation will decrease contractility more and even worsen that CHF. Now, less commonly, beta blockers are used to treat patients with symptomatic hyperthyroidism, or in the very rare but very serious thyroid storm. Sometimes we use them for migraine headaches, especially for prophylaxis, even for anxiety. I have a patient who uses propranolol when they have to give a speech in front of a group of people. It keeps their heart rate down. So we've established that by blocking beta-1, we decrease the heart rate, and this is also going to achieve this by slowing the SA and the AV nodes. So you can use this in patients with a supraventricular tachycardia. However, it also becomes a major side effect as well. So when prescribing these medications, you can certainly cause bradycardia, which can lead to lightheadedness and even syncope. Now, one not so obvious clinical usage of beta blockers is in glaucoma. Beta blockers, when used topically in the eye, things like timolol, nadolol, they can actually decrease the production of aqueous humor. Another use for beta blockers is aortic dissection. So beta blockers are the antihypertensive drug of choice in patients with an aortic dissection, that is if they survive. So in aortic dissection, the high blood pressure is causing that dissection or that tearing between the two layers of the aorta. So you need to lower the blood pressure to prevent this from getting worse, but you don't just reach for any old drug. You typically reach for that beta blocker because beta blockers not only decrease the blood pressure, but they decrease kind of the slope of the rise of the blood pressure. So it's not just the high blood pressure that makes that aortic dissection worse, it's that rapid increase in blood pressure during each beat of the heart. So that's why beta blockers, again, antihypertensive drug of choice for the treatment of aortic dissection. All right, so next let's talk about some of the adverse reactions with our beta blockers. Probably one of the most important adverse reactions with beta blockers is with bronchoconstriction. So this is primarily with the non-selective beta blockers that affect both beta 1 and more specifically that beta 2. That's where you're going to get the bronchoconstriction with beta 2. So if a patient has asthma or COPD, then you probably want to avoid those non-selective beta blockers like propranolol, timolol, and nadolol. And you still need to be careful even with our selective one once you get to higher dosages. Next, beta blockers can decrease glycogenolysis and glucagon release. Therefore, diabetic patients on anti-diabetic medication may be actually at a higher risk of hypoglycemia. Personally, I don't see this very often. Probably more importantly is that beta blockers prevent many of the symptoms associated with hypoglycemia. So when a patient gets hypoglycemic, they get shaky, they can get kind of tachycardic, maybe even confused or anxious feeling, and they can get real sweaty. Beta blockers actually prevent many of these symptoms from happening. Therefore, patients can get even more hypoglycemic and then really not even know it. Now, patients still get sweaty because, as we learned, sweating is stimulated through those muscarinic receptors, not by adrenergic receptors. Now, another point I want to make about beta blockers is when dealing with cocaine, another problem with beta blockers. If you have a patient who comes in with cocaine overdose, maybe they're having a lot of tachycardia, a lot of hypertension, you might want to give them a beta blocker, right? That makes sense. Let's drop that blood pressure. Well, the answer is no. We don't want to give these patients on cocaine a beta blocker. Well, why is that? Well, cocaine is going to cause stimulation of all the adrenergic receptors, not directly, but indirectly. It's going to reduce the reuptake of the monoamines like dopamine, like norepinephrine, like epinephrine. So you just got a ton of that stuff going around. So all of these are going to be acting on all of the adrenergic receptors, alpha 1, alpha 2, beta 1, beta 2, all of them. And remember, it's that beta 2 that's going to cause vasodilation a little bit. It's going to help to sort of kind of temper the hypertensive response of cocaine. So if you give a patient that's on cocaine that beta blocker, you're going to see that stimulation of alpha 1, and that's going to raise their blood pressure. But it's also stimulating beta 2, and that's going to help reduce the blood pressure just a little bit. Well, if we, again, give that patient a beta blocker, it's blocking the beta 1, it's blocking the beta 2 response, and all you have left is unopposed alpha 1 agonism. So you might actually have an increase in the blood pressure when you give a beta blocker to a patient who's already on cocaine. Instead, what are we going to do? We're going to use things like benzodiazepines, maybe even phentolamine, that alpha blocker, to help calm down that sympathetic stimulation in a cocaine overdose. Now, another potential problem is that if you abruptly stop a beta blocker, you can get rebound tachycardia, you can get rebound hypertension, or even arrhythmia if you stop them abruptly. Now, you may have heard that beta blockers cause erectile dysfunction. Now, recent studies have actually found this to be less common and really not all that true. So let's think about that. What controls erection? Remember, there's a mnemonic, point and shoot, for parasympathetic and sympathetic, dealing with erection and then ejaculation. Erection is initiated by the parasympathetic nervous system. So how can we inhibit an erection by inhibiting a receptor in the sympathetic nervous system? Well, you probably can't. And some studies have guessed that this may be a placebo effect because men have been told that beta blockers can cause ED. All right, guys, it's time for another Lewis notes. Let's see if we know which category each beta blocker belongs. All right, hello everyone. Welcome to another Lewis notes. We're looking at our beta blockers, and we're going to put all these into categories because they all end in all or lol. So sometimes it's hard to know what type of beta blocker you're actually dealing with here. So we got all of our beta blockers in the middle. We're going to move them into classification. So first one, atenolol. Atenolol is a selective beta 1 blocker. We're going to use that for hypertension. Great, it's not going to get those beta 2s. Timolol. So timolol is actually used as a glaucoma drug. It's one of those topical beta blockers that we use. Metoprolol. Metoprolol used all the time. One of the most commonly used beta blockers, and that's going to be a selective beta 1. Labetalol. Labetalol is a great one. It's one of those great alpha beta blockers, so it's kind of getting both the peripheral vasodilation, also blocking that regular beta 1 as well. Esmolol. Esmolol, another great medication. It's another selective. It's also very short acting. That's kind of its claim to fame. Next, we have propranolol. Propranolol is a non-selective beta blocker. You can use it for things like hypertension. Sometimes you can use it for essential tremor and even for some anxiety. Acebutolol is another one of these partial agonists. So partial agonists, sometimes they don't get used all that often, but when you do use them, you might use them in someone who already has maybe a low resting heart rate or some bradycardia issues. Carvedilol. Carvedilol is an alpha beta blocker, just like labetalol. Next, we have nadolol. Nadolol is another glaucoma drug, so we're going to use that topically. Nebivolol is all in its own category here. Remember, nebivolol is the one that has that beta-1 blockade, but it also has that nitric oxide vasodilation as well. And then our last one is pindolol. Pindolol is another one of those partial agonists. It's going to act essentially as a beta blocker because it's bind to those receptors, but very, very weakly. All right, so those are going to be all of our beta blockers, and if you know them in their categories, I think that'll help you a lot. All right, so next I want to talk about a couple of drugs that are not antagonists like our previous medications, but they are often used in hypertension. There are, again, as I said before, agonists. Specifically, we're talking about alpha-2 agonists. Now remember that alpha-2 receptors are located on the presynaptic neuron, and they act to inhibit norepinephrine release from that same neuron. Now the two medications are clonidine and alpha-methyldopa. Now we covered clonidine a little bit in the last lecture. Overall, these medications are acting centrally and are decreasing sympathetic tone. Remember, they decrease the release of norepinephrine from the presynaptic neuron. Clonidine can be used in the outpatient setting when the patient is maybe having malignant hypertension. You can give them clonidine orally in the clinic, and it's actually going to work relatively quickly. I generally don't like doing this too often because one of the unfortunate side effects of this medication is rebound hypertension. So you may have improved that blood pressure in the office, but a few hours later that blood pressure may go even higher than it was in the first place. Now clonidine is sometimes used as a sedative, and again that makes sense because it's decreasing the overall sympathetic tone in the body. Now methyldopa, again, not used very often for hypertension by itself. Sometimes it's more like third or fourth line if you're having problems with other medications, but it is still sometimes used in pregnancy-induced hypertension. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. I want you to try to answer those questions on your own and then restart the video, and then we'll go through the answers together. First question, which selective alpha blocker has less effect on blood pressure? Remember, it's that one that works on that very specific 1AD receptor. That's going to be tamsulosin. Next question, what are the common side effects of beta blockers, and which patient population should use caution when taking beta blockers? So common side effects. First, we have that bronchospasm or bronchoconstriction. So you never want to give a non-selective beta blocker to someone who has uncontrolled asthma or COPD. And in general, you probably want to use caution with all beta blockers in these patient populations. Next, beta blockers can lower the blood glucose, maybe slightly. Probably more importantly, they can mask the sympathetic symptoms of hypoglycemia. So you need to use caution when you're giving these beta blockers to diabetic patients. And then next, you can cause things like bradycardia. You can cause AV block, and they can depress myocardial contractility. So you want to use a lot of caution using beta blockers in patients with CHF or patients who have bradycardia. Next, what are the various clinical applications of beta blockers? So beta blockers can be used for a lot of different things. Hypertension, CHF, supraventricular tachycardia. We use a lot in angina in MI patients. And then we're going to use some of those beta blockers in glaucoma patients as well. And then we finally have a couple rapid fire facts here. If we have pheochromocytoma, you're going to use alpha blockers. And for BPH, you're going to use a very selective alpha blocker like tamsulosin. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time. Hello everyone, welcome to another warm-up. Let's get going. What are the three different mechanisms that cells employ to break down proteins? So there's the ubiquitin mechanism with ubiquitin protein ligase. Proteins can be broken down in the lysosomes, and then there are calcium-dependent enzymes as well. Next, what are the components of the blood-brain barrier? So there are three structures that you need to know. We have the astrocyte foot processes, we have the basement membrane, and then we have capillary endothelial cells with tight junctions, which are also called non-fenestrated endothelial cells. Next, a woman involved in an accident cannot turn her head to the left and has a right shoulder droop. What structure is damaged? So this is probably a right-sided sternocleidomastoid muscle that is responsible for the head turning. The right spinal accessory nerve innervates the muscles responsible for these actions. All right, guys, that brings us to the end of the warm-up. Let's get to that lecture.
In this video, we're going to discuss neurotransmission, specifically neurotransmission in the autonomic nervous system. We'll review how neurotransmitters like acetylcholine and norepinephrine are actually made and how they get released and what happens to them once they're released. So let's start with acetylcholine. In your study guide, you're going to find a diagram of a cholinergic nerve terminal, which we're going to label. Now, this gets a little complicated, and there's a lot of information here, but you do need to know this for your exam. This is about a 3-star topic. So how does acetylcholine get released? Well, it starts off with the synthesis of acetylcholine. So here in the upper right, you have two things coming into the presynaptic cell. The first thing being choline. So choline is essential to making acetylcholine. And how does choline get into the cell? Well, there's a sodium cotransporter that brings both choline and sodium into the cell. So the substance that actually drives the transport of choline into the cell is sodium. And this cotransporter can be inhibited by a drug called hemicolinium. Hemicolinium inhibits the transport of choline. Once choline is in the cell, it gets bound to acetyl-CoA. And the enzyme that catalyzes this is called choline acetyltransferase. So choline acetyltransferase takes acetyl-CoA and choline and makes acetylcholine. And that acetylcholine gets packaged into a vesicle. Now, there's a drug that inhibits the packaging of acetylcholine into vesicles, and that drug is visamicol. So when visamicol is around, acetylcholine can't be packaged into the vesicle. So the presynaptic cell is storing acetylcholine in vesicles until it's needed. So what needs to happen for the acetylcholine to be released into the synapse? Well, the substance that's essential for this process is calcium. Calcium is very important in a lot of biological processes, in muscle contraction, in platelet function, in activating the clotting cascade. But here, the influx of calcium triggers exocytosis of these vesicles of acetylcholine. And there are several other things that can inhibit or stimulate the release of acetylcholine into the synapse. So what can stimulate the release of acetylcholine? Well, black widow spider toxin is one worth knowing. So with black widow spider toxin, the synapse is going to be flooded with acetylcholine. And that's going to cause a spastic paralysis. So black widow spider toxin can flood the synapse with acetylcholine. And then one toxin that can inhibit acetylcholine release is botulinum toxin. And this causes a flaccid paralysis. You just can't contract your muscles without acetylcholine that's stimulating the nicotinic receptors at your muscles, so you get flaccid paralysis. And then the diagram says 4 fates of acetylcholine. So you successfully released acetylcholine into the synaptic cleft, but what happens next? Well, one of 4 things can happen to that acetylcholine. First of all, it can do what it's intended to do, which is to bind to its postsynaptic receptor. Second, it can bind to an autoreceptor on the presynaptic cell, which regulates further acetylcholine release. Third, it can simply diffuse away from the synaptic cleft. And the fourth thing that can happen to acetylcholine, it can be degraded by acetylcholinesterase, which cleaves acetylcholine into choline and acetate. That choline can be recycled and transported back into the cell by the sodium cotransporter. And what drug category would inhibit this cholinesterase from degrading acetylcholine? The cholinesterase inhibitors, like neostigmine. Let's move on to the noradrenergic nerve terminal next. Now, in order to understand what's going on in the noradrenergic nerve terminal, we need to go over the steps of catecholamine synthesis. Now, it's pretty straightforward, but unfortunately, you do need to memorize the steps and the enzymes and the cofactors, but not necessarily the chemical structures. So just listen for right now. We're going to write this out in a second. You start with the amino acid phenylalanine, and the enzyme phenylalanine hydroxylase adds a hydroxyl group to make tyrosine. Now, what happens if you're deficient in phenylalanine hydroxylase? Well, the phenylalanine builds up and leads to phenylketonuria, or PKU. So phenylalanine hydroxylase is an important enzyme to know. And this enzyme uses a cofactor called tetrahydrobiopterin, or BH4, which gets converted to BH2, dihydrobiopterin, in the process. And there's an enzyme called dihydrobiopterin reductase that converts BH2 back to BH4, so it's ready to go again. And if you're deficient in that enzyme, phenylalanine will build up and you'll get PKU. So there are 2 ways to get PKU. We'll talk more about PKU in biochem. So you've converted phenylalanine to tyrosine. Then the next enzyme is tyrosine hydroxylase, which adds another hydroxyl group to make DOPA. This also uses BH4. Now, DOPA stands for dihydroxyphenylalanine. So we started with phenylalanine, we added 2 hydroxy groups to get dihydroxyphenylalanine, or DOPA. The next enzyme is called DOPA decarboxylase, which removes a carboxyl group from DOPA, so you have dopamine. And there's an important cofactor for this enzyme, which is vitamin B6, pyridoxal phosphate. Then the enzyme dopamine beta hydroxylase comes along and adds another hydroxyl group to the side chain on dopamine, and that makes norepinephrine. And here, vitamin C is the cofactor. And then finally, the enzyme called PNMT, or phenylethanolamine N-methyltransferase, transfers a methyl group to the side chain, and that produces epinephrine. And this step is stimulated by cortisol. Now, in your study guide, there's a place for you to write down this pathway, so let's simplify it a little bit. You start by converting phenylalanine to tyrosine using the enzyme phenylalanine hydroxylase.
and the cofactor required is BH4. Then you convert tyrosine to levodopa using the enzyme tyrosine hydroxylase and the same cofactor, BH4. Then you convert levodopa to dopamine using the enzyme dopa decarboxylase and the cofactor vitamin B6. Then you convert dopamine to norepinephrine using the enzyme dopamine beta hydroxylase and vitamin C as a cofactor. And finally, you convert norepinephrine to epinephrine using the enzyme PNMT, and this is the step that's stimulated by cortisol. So those are the main steps of catecholamine synthesis.
Now let's look at the noradrenergic nerve terminal, which is where norepinephrine is released. We start out by bringing tyrosine into the cell. And tyrosine comes into the cell using a sodium cotransporter, using the extracellular sodium gradient to bring tyrosine in. Once tyrosine is in the cell, the enzyme tyrosine hydroxylase converts tyrosine to dopa, and there's a drug that can inhibit this step called metyrosine. Then dopa is converted to dopamine by the enzyme dopa decarboxylase. And we're not going to fill in all the enzymes on this diagram. Then dopamine is converted to norepinephrine, and norepinephrine is packaged in the vesicle. Then there's a drug that can inhibit this packaging of the norepinephrine into the vesicles, which is called reserpine. And what substance causes vesicles to fuse with the cell membrane and release the contents of the vesicle into the synapse? It's calcium, just like in cholinergic nerve terminals. But besides calcium, what other substances stimulate norepinephrine release? Well, one thing is amphetamines. Some amphetamines will facilitate the release of norepinephrine into the synapse. And ephedrine works the same way. And then another substance worth knowing is tyramine. So the three substances I want you to know that can facilitate norepinephrine release into the synapse are amphetamine, ephedrine, and tyramine. Now, what can inhibit the release of norepinephrine? Well, the two drugs I want you to know are guanethidine and beryllium. Beryllium is a potassium channel blocker used as an antiarrhythmic for heart rhythm disorders. And one of the things it can do is inhibit the release of norepinephrine vesicles. Now, once the norepinephrine has been released, what can happen to it? What are the fates of norepinephrine? Well, it can bind to one of the adrenergic receptors on the postsynaptic cell, such as alpha-1 or beta-1 receptors, or it could bind to an alpha-2 autoreceptor on the presynaptic cell, which is going to inhibit further norepinephrine release. And there are other receptors on the presynaptic cell that can regulate this release of norepinephrine, such as the M2 muscarinic receptors. Think about it. If you have parasympathetic muscarinic activity going on, you want to simultaneously inhibit adrenergic activity. And then angiotensin receptors will facilitate norepinephrine release. So those are two of the fates of norepinephrine. It can bind to a postsynaptic receptor or it can bind to a presynaptic autoreceptor. A third potential fate of norepinephrine is reuptake, which you can see right here. One of the main ways that norepinephrine gets out of the synapse is it gets taken back up by the presynaptic cell. And there are several substances that inhibit this reuptake that are worth knowing. Cocaine, tricyclic antidepressants, and also the SNRIs, serotonin norepinephrine reuptake inhibitors, like venlafaxine or duloxetine. So cocaine, TCAs, and SNRIs all inhibit norepinephrine reuptake. So that's why cocaine makes the heart race and raises the blood pressure. That's why TCAs and SNRIs are useful in treating depression. The fact that ephedrine increases norepinephrine release explains why ephedrine supplements in energy drinks and appetite suppressants can be so dangerous. And this is why tyramine can cause hypertensive crisis in patients that are on certain medication. It all ties into norepinephrine release and reuptake. There's also a fourth potential fate of norepinephrine, which is that it can be metabolized, not necessarily right here within the synapse, but there are a couple of enzymes that do metabolize norepinephrine. One of those enzymes is catechol O-methyltransferase, or COMT. Now the thing I want you to know about this is that it methylates norepinephrine. It's a methyltransferase. It transfers a methyl group onto norepinephrine. Another enzyme that can metabolize norepinephrine is monoamine oxidase, or MAO. And this oxidizes norepinephrine. So the methyltransferase is going to methylate norepinephrine, and monoamine oxidase is going to oxidize norepinephrine. Now, both of these reactions are going to make norepinephrine unusable as a neurotransmitter. So if you have a pheochromocytoma that's making lots of catecholamines like dopamine and norepinephrine and epinephrine, these two enzymes, COMT and MAO, will convert those catecholamines to things like metanephrine and normetanephrine and VMA, which you can test for in the urine to help make the diagnosis. Specifically, these enzymes convert dopamine into HVA, or homovanillic acid. They convert norepinephrine into VMA, or vanillylmalonic acid, and they convert epinephrine into metanephrine. Now, you're going to see this again when we cover pheochromocytoma in the endocrine section. And you'll also see COMT and MAO when we discuss Parkinson's disease, because Parkinson's disease is characterized by a deficiency of dopamine in the brain, and we use drugs that inhibit COMT and inhibit MAO as a way to raise dopamine levels in Parkinson's patients. And MAO inhibitors, or MAOIs, have also been used as antidepressants. Now, we don't really use them much anymore, but increasing norepinephrine can treat depression, just like we saw with the TCAs and the SNRIs. So again, it's important to understand both the catecholamine synthesis pathway and also the drugs that affect adrenergic neurotransmission. All right, before we get to the end of session quiz, let's do a quick review.
In this whiteboard review, I've listed several drugs and toxins on the left, and we're going to match them up with their actions on the autonomic nerve terminals. The first one here is amitriptyline, which is a tricyclic antidepressant, a TCA. And we said that those inhibit norepinephrine reuptake. The next one is amphetamine, which we said stimulates norepinephrine release. Then we have black widow spider toxin, which stimulates acetylcholine release. Botulinum toxin inhibits acetylcholine release. Beryllium inhibits norepinephrine release. Cocaine inhibits norepinephrine reuptake. Guanethidine inhibits norepinephrine release again. Hemicolinium inhibits choline transport. And you can remember the choline and hemicolinium. It's pretty obvious. Reserpine inhibits the packaging of norepinephrine into vesicles. And visamicol, again, the chol tells you it inhibits packaging of acetylcholine into vesicles. So, all right, you did a great job on that one. And for your reward, since we mentioned amphetamine, I'm going to draw you a little Heisenberg.
Now it's time for the end of session quiz. So go ahead and work through the questions, and then we'll go over these answers together. All right, first question. Which three enzymes are required to convert phenylalanine to dopamine? So you need phenylalanine hydroxylase, which converts phenylalanine to tyrosine. You need tyrosine hydroxylase, which converts tyrosine to dopa. And you need dopa decarboxylase to convert dopa to dopamine. Next, a patient develops paralysis after being bitten by a black widow spider. Is this a spastic or a flaccid paralysis? And what other autonomic symptoms might be seen? So remember, black widow spider toxin stimulates the release of acetylcholine, which is the neurotransmitter at the neuromuscular junction. So that causes muscle spasms and possibly some spastic paralysis. And the other symptoms might include salivation, diaphoresis, lacrimation, all from excess acetylcholine. Everything gets leaky. Next, what substances inhibit the reuptake of norepinephrine? We mentioned cocaine, tricyclic antidepressants, and SNRIs. Next, what substances stimulate the release of norepinephrine from neurons? So calcium is the normal trigger for the release of norepinephrine. Then also we mentioned amphetamines, ephedrine, and tyramine. All right, I'll see you next time.
It's time for another warm-up review. Let's get going. Damage to which artery would produce each of the following presentations? So first we have bilateral loss of lateral visual fields. So this is the anterior communicating artery aneurysm compressing on the optic chiasm. Broca or Wernicke aphasia. So that's going to be the middle cerebral artery stroke. Next we have unilateral lower extremity sensory and/or motor loss. This is going to be the anterior cerebral artery stroke. Unilateral facial and arm sensory and/or motor loss. This is going to be the middle cerebral artery stroke again. Next, which diuretic is used in the treatment of idiopathic intracranial hypertension? Acetazolamide. So we don't actually use this much for diuresis, but we use it for pseudotumor cerebri and glaucoma and altitude sickness. Next, when does implantation of the blastocyst take place? So that's going to be 6 days after fertilization. All right, that's it for the warm-up. Let's get to that video.
In this video, we're talking about receptors, especially the cholinergic and adrenergic receptors, and how these receptors make things happen inside cells on a molecular level. And we often talk about the effects of norepinephrine or acetylcholine or dopamine or BNP, but it really depends on what the receptor the chemical interacts with. The receptor is what determines the downstream effects. Now, the main types of receptor we're going to focus on in this video are called G-protein linked receptors. And we're focusing on them because G-protein receptors are about a 4-star topic for step 1. So as we dive into this crazy detail, keep in mind this is something you're likely to be tested on.
Now, when you stimulate a receptor on the surface of a cell, there are several different mechanisms that translate that signal into some kind of signal inside the cell to make things happen. For example, back in Foundations, we talked about tyrosine kinase receptors on the plasma membrane. Well, G-protein receptors are another type of receptor on the plasma membrane. This G-protein receptor has a protein that passes through the plasma membrane 7 times. It's usually depicted like a big bundle of sticks, but sometimes it's referred to as a 7-pass transmembrane receptor. It's also known as a G-protein linked receptor because it's associated with this G-protein, which we've depicted in blue, and it activates the G-protein to do something. So let's review some different classes of receptors and what downstream effects they have, starting with cholinergic receptors. Remember, there are 2 flavors of cholinergic receptors, nicotinic receptors and muscarinic receptors. Now, nicotinic receptors are ligand-gated ion channels. Acetylcholine binds to the receptor and the ion channel opens up and it lets cations like sodium and potassium enter the cell. So, nicotinic receptors don't use G-proteins. But the muscarinic acetylcholine receptors are G-protein linked receptors. So let's talk about muscarinic receptors for just a minute. There are several subtypes of muscarinic receptors, which are M1, M2, and M3. And actually there's also M4 and M5, but we're just going to focus on M1, M2, and M3. The M1 muscarinic receptors are found in the enteric nervous system, where they help the gut rest and digest. M2 receptors are going to decrease cardiac contractility and decrease the heart rate at the SA node. And then the M3 receptors are going to increase bladder contraction and increase gut peristalsis to start making things leaky, right? M3 receptors in the tear glands cause lacrimation or tearing. They also cause meiosis, and they cause some bronchoconstriction. Now, you've seen all those parasympathetic effects before. You just need to recognize that there are different classes of muscarinic receptors in different target tissues. Then for the adrenergic receptors, you're already familiar with the subtypes of adrenergic receptors like alpha-1, alpha-2, beta-1, and beta-2. So let's start with the alpha receptors. Stimulation of alpha-1 receptors causes vascular smooth muscle contraction. So alpha-1 receptors cause vasoconstriction. That's why epinephrine and norepinephrine will raise the blood pressure because they're stimulating those alpha-1 adrenergic receptors. Now alpha-2 receptors are the presynaptic autoreceptors. They inhibit further norepinephrine release. So alpha-2 stimulation inhibits sympathetic outflow, and it's going to inhibit some of that alpha-1 mediated vasoconstriction. That's the main action. Just to confuse things a little bit, alpha-2 receptors are also found on certain blood vessels where they do cause a little bit of vasoconstriction. Now beta-1 receptors increase heart rate and they increase myocardial contractility. That's why adrenaline makes your heart pound in your chest. Beta-2 receptors cause vasodilation and also some bronchodilation. So for beta-1, I want you to think about increased heart rate and contractility. For beta-2, I want you to think about vasodilation and bronchodilation. So muscarinic receptors and adrenergic receptors are all G-protein receptors. They're all 7-pass transmembrane receptors that activate G-proteins to do something. But G-proteins are also found associated with other types of receptors outside the autonomic nervous system. So there are dopamine receptors. Dopamine is another catecholamine, but it's not part of the autonomic nervous system. Dopamine is mainly a neurotransmitter in the brain. So D1 dopamine receptors will relax renal vascular smooth muscles, and then D2 dopamine receptors are mainly located in the brain. Histamine receptors also use G-proteins. H1 histamine receptors are responsible for allergy symptoms like nasal secretions and bronchial mucus production. They're going to cause pruritus or itching and also some bronchoconstriction. So that's why if a patient's having an allergic reaction, we can give an antihistamine to help relieve some of those allergic symptoms, to block those H1 receptors. Then H2 histamine receptors increase gastric acid secretion. So if you want to inhibit allergy symptoms, you're going to give an antihistamine to inhibit H1 receptors. If you want to inhibit gastric acid production, such as in a patient with a peptic ulcer, you might give an H2 blocker like cimetidine or ranitidine. Then one more group of receptors that are linked to G proteins are the vasopressin receptors. Now there are 2 different subtypes of vasopressin receptors. V1 vasopressin receptors cause vascular smooth muscle contraction. So sometimes vasopressin is given during codes to cause some vasoconstriction. And then the V2 vasopressin receptors are going to increase reabsorption in the collecting tubules of the kidney. So remember, another name for vasopressin is antidiuretic hormone, or ADH. And ADH leads to an antidiuresis, or a reduction in urine volume. And it does that by stimulating these V2 receptors in the kidneys, which again increases resorption of fluid in the collecting tubules of the kidneys. So I count 13 different receptor classes that you need to know as being linked to G proteins. So these are G protein linked receptors. M1, M2, and M3 muscarinic receptors, and again those respond to acetylcholine. Alpha 1, alpha 2, beta 1, and beta 2 adrenergic receptors, which respond to epinephrine and norepinephrine. You have the D1 and D2 dopamine receptors, the H1 and H2 histamine receptors, and the V1 and V2 vasopressin receptors. Now let's look at how these G protein receptors work in some detail. And again, this does get tested pretty regularly. Each of these neurotransmitters and signaling chemicals activates a specific type of receptor, and each receptor is in turn utilizing a specific type of G protein. And the G proteins come in 3 distinct flavors: GQ, GI, and GS. So, what does a GQ protein do? A GQ protein, once it's activated by its specific neurotransmitter, is going to activate an enzyme called phospholipase C. So, take norepinephrine as an example. Norepinephrine activates an alpha-1 receptor, and that alpha-1 GQ protein is going to then activate phospholipase C. Phospholipase C is going to act on a chemical called phosphatidylinositol bisphosphate. And that's a mouthful, so we abbreviate it PIP2, phosphatidylinositol bisphosphate. So phospholipase C cleaves PIP2 into 2 chemicals, IP3 and DAG, and both of these have downstream effects. IP3 is inositol triphosphate, and inositol triphosphate increases intracellular calcium. Again, calcium is very important. That increase in intracellular calcium can then mediate any number of different effects. And then the other chemical here, when PIP2 is cleaved, it also produces DAG, which is diacylglycerol. And that diacylglycerol has the downstream effect of activating an enzyme called protein kinase C. So the downstream effect of activating phospholipase C is the activation of protein kinase C. So that's pretty easy to remember. Associate those C's together. And then also C for calcium. So I want you to remember that GQ activates C, Q and C. And there's a great mnemonic. Cute C's have 1 M&M. Cute C's is like a cute little kid, a cutesy, but it's also Q and C. So cutesies have 1 M&M. And the have 1 M&M tells you which receptors utilize this GQ protein. So there's H1, alpha 1, and V1. The histamine 1 receptor, the alpha 1 receptor, and the vasopressin 1 receptor. That's the have 1 part of the mnemonic. And then the M&M is for M1 and M3. So remember, cutesies have 1 M&M, and remember all the C's in that GQ pathway: phospholipase C, protein kinase C, and calcium. And you've got it. Now, it's almost totally clinically irrelevant, but you will be tested on it, so you need to know it. So GQ is the first type of G protein. Then the second type of G protein is GS, and the S is for stimulates. So what's it stimulating? Well, it's stimulating adenylyl cyclase. And adenylyl cyclase, what does it do? Well, it converts ATP to cyclic AMP. And then cyclic AMP is a modulator that has the downstream effect of activating protein kinase A. So GS stimulates adenylyl cyclase to convert ATP to cyclic AMP, which activates protein kinase A. And then GI is the third type of G protein, and I is for inhibit. So GI inhibits adenylyl cyclase. So you have less production of cyclic AMP and less activation of protein kinase A. So of all of those receptors, D1 and D2 and beta 1 and alpha 2, out of all of those, which ones use GS and which ones use GI? Well, the mnemonic for the GI-linked receptors is the MAD2s. I think of inhibit and MAD as being negative words, so they kind of go together. So GI is the MAD2s. M in MAD is for M2, A is for alpha 2, and D is for the dopamine D2 receptors. So the MAD2s. So if you can remember those 2 mnemonics, cutesies have 1 M&M for GQ, and then the MAD2s for GI, then you can just know that the GS protein is the default, and all the other G protein receptors we listed are going to use the GS mechanism. So that includes beta 1, beta 2, D1, H2, and V2. Now let's take a look in your study guide at the chart titled Signal Transmission Pathways. At the top, there's a complex pathway that summarizes G proteins a little bit differently. And then underneath that, we've replaced the steps with numbers so you can quiz yourself. Now, I'm not going to go through all of this again, but let's hit some of the high points. Over here on the left, the hormone or transmitter binds to that 7-pass transmembrane receptor, which is linked to a G protein. And then following it down, you have activation of the alpha subunit of the G protein, which then activates adenylyl cyclase, cyclic AMP, and protein kinase A. So, which G protein does that? That's GS, S for stimulate, right? And then down in the middle, this would be a different receptor because it's a different second messenger pathway. Here, the activation of the G protein activates phospholipase C and IP3 and increased calcium, and then DAG and activation of protein kinase C. So which G protein would do that? That would be GQ. Now the other way to get to this phospholipase C pathway is with a tyrosine kinase receptor. You start with a growth factor binding to a tyrosine kinase receptor. So what kind of transmitter uses a tyrosine kinase receptor? Well, none of the things we've been talking about. Dopamine and acetylcholine and all these other transmitters use G protein linked receptors. For tyrosine kinase receptors, we're mostly talking about things like insulin and prolactin, and also several growth factors like insulin-like growth factor, fibroblast growth factor, platelet-derived growth factor, growth hormone. So all of those use a tyrosine kinase receptors. And there are two different pathways that a tyrosine kinase receptor can use. One pathway is similar to the GQ pathway in that it activates phospholipase C. But the other pathway, the more well-known tyrosine kinase pathway, is the RAS activating pathway. You have an adaptor protein that activates the RAS activating system, and then that activates protein kinase 1, 2, and 3. And then that has a downstream effect. So these pathways are important to understand. Again, it's about a 4-star topic. So make sure you know the difference between GQ, GS, and GI. Make sure you know what each of those different G protein receptors does. Make sure you know what these pathways look like and be able to draw out these pathways in your mind. All right, before the end of session quiz, let's do another whiteboard review. In this whiteboard review, we're going to match the 3 different classes of G proteins to their actions. So we have GI, GQ, and GS. So let's start out with GI. Remember we said GI, the I stands for inhibit, so GI starts out by inhibiting adenylyl cyclase, and that leads to decreased cyclic AMP, and that leads to less activation of protein kinase A. Then for GQ, GQ is the Hansen protein. You can remember Q and C. So we start out GQ activates phospholipase C, and that phospholipase C is going to cleave PIP2 to IP3 and DAG. So here we have 2 actions. The IP3 is going to increase calcium. We'll draw a little arrow there. And then the DAG is going to activate protein kinase C. And then for GS, remember GS, S is for stimulate, so GS stimulates adenylyl cyclase, and that's going to increase cyclic AMP, and that will activate protein kinase A. Now let's also practice listing the transmitters that go with each of these. So GI, remember the mnemonic is the MAD2s. So for GI we have M2, alpha 2, and D2. Then for GQ, that's cutesies have 1 M and M. So that's H1, alpha 1, V1, and then M1 and M3. And why is it M3? Well, you know it's M3 and not M2 because M2 goes with the MAD2s. And then GS is all the leftover receptors. So you really need both of these mnemonics. So for GS you have beta 1, beta 2, H2, V2, and D1. All right, good job on this one. So for that you get 10 gold stars. So now it's time for the end of session quiz. So go ahead and work through the quiz and then we'll go over the answers together. All right, this is a short quiz, but again, it's very, very high yield. First question, what G protein class does each of the following receptors stimulate? So alpha 1 is GQ, alpha 2 is GI, beta 1 is GS, and beta 2 is also GS. M1 is GQ, M2 is GI, M3 is GQ, and then D2 is GI. And the last question, outline the pathway by which stimulation of a GS receptor activates protein kinase A. So the GS receptor activates adenylyl cyclase, and then adenylyl cyclase turns ATP into cyclic AMP, and then cyclic AMP activates protein kinase A. That's it for now, but we're going to keep quizzing you on these G protein pathways throughout the course in the warm-up quizzes because you really do need to know them. So I'll see you next time.
It's time for another warm-up review. let's get going. Label the following diagram of the circle of Willis. Good anatomy here. First we have letter A. That's going to be the anterior cerebral artery. Letter B is going to be the anterior communicating artery. C is the middle cerebral artery. D is the internal carotid artery. E is the posterior communicating artery. F is the posterior cerebral artery. G is the superior cerebellar artery. H is the basilar artery. I is the anterior inferior cerebellar artery. J is the vertebral artery. K is the PICA, the posterior inferior cerebellar artery. And L is the anterior spinal artery. All right, that's it for the warm-up. Let's get to the lecture now.
In this video, we're going to talk about pharmacokinetics and enzyme kinetics. Now, this isn't necessarily clinically relevant, and most students don't find it particularly exciting. But this is very high yield for step 1. Now, I'm going to focus on what's most important for your exam, so make sure you really understand pharmacokinetics and pharmacodynamics really well. Let's start with enzyme kinetics, which is at least a 4, maybe a 5-star topic. You should expect at least one question on enzyme kinetics, Km, and Vmax, maybe several questions. Students often tell us you need to know Km and Vmax like the back of your hand for step 1. Let's start with Michaelis-Menten kinetics. Say you have an enzyme that catalyzes some reaction, and you mix some of that enzyme with the substrate, which is S, and you measure the velocity of that reaction. Well, this graph shows you how the reaction velocity changes as the concentration of substrate changes. So the x-axis is the concentration of substrate, and the y-axis is the reaction velocity. So the first thing to notice is that down here, as the substrate concentration increases, the reaction velocity increases. More substrate leads to faster reactions. We call this first-order velocity, where the reaction velocity is directly proportional to the concentration of substrate. But as you continue to add more and more substrate, eventually you're going to saturate the enzyme. And once that enzyme gets saturated, you can't make the reaction go any faster no matter how much substrate you add. So up here, the enzyme is completely saturated and the reaction velocity reaches a plateau. We call this zero-order velocity or zero-order kinetics because the velocity is completely independent of the substrate concentration. It doesn't matter if you've got 1,000 particles of the substrate or 1,000,000 particles. If there are only enough enzyme binding sites for 100 particles, the velocity of the reaction is going to be the same. And we call this maximum reaction velocity Vmax. That's the maximum velocity that the reaction can achieve. If you wanted to speed up the reaction, how would you do it? Well, the enzyme is saturated, so the only way to speed things up would be to add more enzyme. Now, if you add more enzyme, you have more binding sites, and that shifts the whole graph up some, and Vmax is a little higher. So ultimately, Vmax is proportional to the amount of enzyme that's available. Okay, so what's Km? Km is called the Michaelis constant, but that name isn't really important. What is important is that you know that Km is a substrate concentration. Specifically, it's the concentration of substrate that gets your reaction to half of Vmax. It's the amount of substrate that's required for the enzyme to achieve half of the maximum velocity that that enzyme can achieve. So Km is a substrate concentration. If you look at this graph, you would say this is Vmax, and when half of Vmax is here, halfway between Vmax and 0. Then wherever that half Vmax is, you follow that out horizontally to intersect the graph, then drop down vertically to the x-axis, and whatever that concentration is, that's Km. So Km is the substrate concentration at 1/2 of Vmax. It's really pretty straightforward. Now, Km is determined by the enzyme's affinity for its substrate. If the enzyme has higher affinity for the substrate, the reaction gets to Vmax very quickly, and the slope of the graph is steeper, so Km will be lower. So a lower Km means that the enzyme has higher affinity for the substrate. It doesn't take as much substrate to get to half Vmax. Now let's look at this a different way. This is called a Lineweaver-Burke plot. It's the same data, but it's plotted on different axes. In a Lineweaver-Burke plot, the x-axis is 1 over S, 1 over the substrate concentration. And the y-axis is 1 over V, 1 over the reaction velocity. And what that does is kind of straighten out the curve. Now, the 3 points you have to know about this, and I really think you just have to memorize it because there's no great way to reason it out, but the 3 points to memorize are the slope of this graph, the x-intercept, and the y-intercept. So the slope of a Lineweaver-Burke plot is Km over Vmax. The x-intercept is the point where the graph crosses the x-axis, and that's 1 over minus Km. And the y-intercept is 1 over Vmax. Now, we mentioned that in a reaction that's reached Vmax and all the enzyme sites are saturated, the only way to speed up the reaction or to raise Vmax is to add more enzyme. So when you add more enzyme and increase Vmax, this graph flattens out. Vmax is higher, the y-intercept is lower, and the slope is lower. But Km hasn't changed because we said Km is related to the enzyme's affinity for the substrate. Changing the enzyme concentration doesn't really change the enzyme's affinity for the substrate. Increasing the y-intercept means you have a lower Vmax because it's inversely proportional. And the further to the right the x-intercept is, the greater the Km. So you need to understand how a change to Vmax or Km is going to affect a Lineweaver-Burke plot. Now let's talk about what happens to Vmax and Km when you add an inhibitor, either a competitive inhibitor or a non-competitive inhibitor. Normally, a substrate binds to the active site of the enzyme, and the enzyme catalyzes some reaction. A competitive inhibitor is a substance that prevents the substrate from binding to the active site of the enzyme. This is usually because the inhibitor resembles the substrate, and the inhibitor binds directly to the active site. It competes for the active site. But if you give enough substrate, you can dilute out that competitive inhibitor so that it's basically irrelevant. So competitive inhibitors can be overcome by increasing the amount of substrate. A non-competitive inhibitor is a substance that changes the three-dimensional conformation of the enzyme so that even though the substrate can still bind to the active site, the enzyme activity is reduced. That three-dimensional conformation is crucial for normal protein function. Usually, non-competitive inhibitors bind to the enzyme allosterically, meaning they bind at some site other than the normal substrate binding site. But the important thing in terms of enzyme kinetics is that you cannot dilute out a non-competitive inhibitor by adding more substrate. So how do inhibitors affect our enzyme kinetics graphs? Well, a competitive inhibitor does not change Vmax. You can still achieve that same maximum velocity eventually if you give enough substrate. So with a competitive inhibitor, the Michaelis-Menten curve is shifted to the right. It takes a higher substrate concentration to reach Vmax, but Vmax doesn't change. With a non-competitive inhibitor, you cannot overcome the inhibition by giving more substrate. At some point, you're going to saturate the available enzyme and reach zero order velocity. And what you'll find is that when you reach that plateau, the Vmax is lower. So non-competitive inhibition will decrease Vmax, but it does not change Km. Now, what does that look like on a Lineweaver-Burke plot? Here, the yellow line represents the uninhibited enzyme. Now, when you add a competitive inhibitor, does that affect the Vmax? Competitive inhibitors do not change Vmax. Vmax is related to the enzyme concentration. So if a competitive inhibitor does not change Vmax, that means the y-intercept doesn't change. But it does change your x-intercept, which means Km is changing. A competitive inhibitor increases Km because Km is the substrate concentration at half Vmax. It takes more substrate to get to half Vmax with a competitive inhibitor on board. What about a non-competitive inhibitor? A non-competitive inhibitor decreases enzyme activity and reduces Vmax, but it does not change Km. So with a non-competitive inhibitor, the x-intercept doesn't change, but the y-intercept is going up, and that means a lower Vmax. So a non-competitive inhibitor decreases Vmax. Let's take a second and practice these. In your study guide, we have some unlabeled graphs, first without inhibitors and then with inhibitors. So I want you to pause the video and try to label these graphs, and then we'll talk through the answers together. On the Michaelis-Menten graph, A is Vmax, B is 1/2 Vmax, and then C is Km, which is the concentration of substrate needed to achieve 1/2 Vmax. D is indicating the region of first order velocity, and E is indicating the region of zero order velocity. And on the Lineweaver-Burke plot, F is 1 over minus Km, and G is 1 over Vmax. You're probably just going to have to memorize those two. Then on the graphs with the inhibitors, A is a competitive inhibitor, where you're increasing Km, but Vmax is unchanged. And B is a non-competitive inhibitor, where Vmax is decreased. Then on the Lineweaver-Burke plot, C is a non-competitive inhibitor, where Vmax is lower, so the y-intercept is moved up. And D is a competitive inhibitor, where you're changing Km. Let's go over some basic pharmacokinetic calculations. And again, this is hugely high yield. I know these equations can be intimidating, and some of this you just have to memorize so that you can just plug in the numbers into the equations. Fortunately, there are only 4 pharmacokinetic equations that you need to know. You should be able to answer all the calculation questions on your exam with just these 4 equations. And there's a page in your study guide where you can write down these 4 equations as we go through them. The first equation is the volume of distribution equals the amount of drug in the IV form divided by the concentration of the drug in the plasma. So that's VD equals D over C. And we say the IV form because basically we're factoring out bioavailability. When you give a drug IV, it's 100% bioavailable. So volume of distribution is the amount of drug given divided by the plasma concentration of the drug. The second equation deals with clearance. Clearance is the rate of elimination of a drug divided by the plasma drug concentration. Clearance is also equal to 0.7 times the volume of distribution divided by the half-life of the drug. And that's the equation you should probably memorize. Another way you can remember that is that clearance is K times the volume of distribution. So K is the elimination constant, and these 2 equations together tell us that K is 0.7 divided by the half-life. So clearance is equal to the elimination constant times the volume of distribution, where the elimination constant is 0.7 divided by the half-life. The third equation is a loading dose. Loading dose is equal to the concentration at steady state times the volume of distribution. So what's the concentration at steady state? Well, that's your desired concentration, your target concentration. You're giving a drug, and you know you have to get it up to a certain plasma concentration where it's going to have the desired effect. So to determine the loading dose, you need to decide what your desired concentration is, and then multiply that by the volume of distribution. And then the fourth equation is the equation for maintenance dose. Once you've got the drug up to that desired concentration, you have to keep giving a dose every day or every 8 hours or whatever it might be in order to maintain that steady state concentration. So the equation for maintenance dose is the steady state concentration times the clearance. So those are the 4 equations you definitely need to know for your test: volume of distribution, clearance, loading dose, and maintenance dose. Make sure you memorize those equations. Now, the best way to show you how to use these equations is to work through some questions, plugging in the numbers, which we're going to do in the end of session quiz. These equations are a great example of what we call a marker board topic. When you go into the testing center to take step 1, after you've checked in and you sit down at your computer station, they're going to give you a marker board and a dry erase marker. The marker board is just a couple of sheets of paper that have been laminated. And we recommend that the first thing you do as soon as your first block starts is to spend just a couple of minutes writing down some equations and facts so you can move through the test quickly. Now, if you look at the very last page of the DIT study guide, you're going to find some test day tips, which we'll talk about later on in the course. And on that page is a short list of some recommended marker board topics, which includes these 4 pharmacokinetic equations. That way, when you get a question about pharmacokinetics later on in the exam, you don't have to panic. You just start plugging in the numbers. So make sure you have these equations memorized and you can write them down accurately and quickly. If you practice writing them down 1 time every day between now and your test, you're guaranteed to have them locked in. Now, one other thing to be aware of when you're calculating loading dose and maintenance dose is bioavailability. Bioavailability takes into account the fact that a lot of the time when you take a drug orally, you only absorb some of the drug. All the drug doesn't actually get into the blood. Most oral drugs have bioavailability less than 100%. So sometimes you'll see an equation that says loading dose equals the concentration at steady state times the volume of distribution divided by F, where F is the bioavailability. Well, the good news is that we've never heard of students having questions that ask you to adjust for bioavailability. So the question will either specifically say it's 100% bioavailable in oral form, or the question will say that the drug is given IV. So I think it's pretty safe to just forget about F when you're memorizing all these equations. Let's say a quick word about half-life. Half-life is the amount of time it takes to eliminate half of the drug that's in the body. And if you're infusing a drug at a constant rate, that drug is going to reach about 94% of the steady state concentration in approximately 4 half-lives. That's the number you want to know. 94% after 4 half-lives. So if you're infusing that drug constantly, it's going to hit 94% of steady state at 4 half-lives of the drug. And then it's also going to be eliminated in the same way. When you stop the infusion and let a patient sit for 4 half-lives, about 94% of the drug is going to be eliminated during that time. So it kind of goes both ways. So I would know these numbers. After 1 half-life, obviously you've eliminated 50% of the drug. At 2 half-lives, you eliminate 50% of whatever's left, which is another 25%. So now you've eliminated 75% of the starting amount. At 3 half-lives, you've eliminated 87.5%. And at 4 half-lives, you've eliminated 94%. And again, those work the other way too. If you're giving a drug, after 1 half-life, you've achieved 50% of the steady state concentration. After 2 half-lives, you've achieved 75% of steady state, and on up to 94% after 4 half-lives. And again, those numbers are worth knowing. So now we're ready to tackle the end of session quiz, which is going to focus entirely on doing calculations with our 4 pharmacokinetic equations. All these quiz questions deal with this scenario. A 60-kilogram man with status asthmaticus is being given an IV infusion of a drug X at 60 milligrams per hour. The clearance of drug X is 2 liters per hour, and the volume of distribution is approximately 0.5 liters per kilogram. 48 hours after administration has begun, the asthma attack is under control. At this time, the concentration of drug X in his plasma is 20 milligrams per liter. So go ahead and try to answer all these questions on your own, and then we'll work through them together. All right, the first question says, what's the half-life of drug X in this patient? So you start with the equation for clearance. Clearance equals 0.7 times the volume of distribution divided by the half-life. Then you switch that around and you get half-life equals 0.7 times the volume of distribution divided by the clearance. So to figure out the answer, you need the volume of distribution and you need the clearance. Well, the clearance was given. It said the clearance of drug X is 2 liters per hour. And the volume of distribution is kind of given. It says volume of distribution is 0.5 liters per kilogram, but liters per kilogram is not a unit for volume. Don't ignore the units in these problems. Volume is just liters, not liters per kilogram. So if this patient is 60 kilograms, the volume of distribution for this drug in this patient is 0.5 times 60, which gives you 30 liters. So the volume of distribution here is 30 liters, and you multiply that by 0.7 and divide by your clearance, which is 2, and you get 10.5. So the half-life here is 10.5 hours. Next, what loading dose could have been used to reach the target concentration of 20 milligrams per liter? So in order to calculate your loading dose, you take the target concentration of 20 milligrams per liter and multiply it by the volume of distribution, which you found was 30 liters, and you get a loading dose of 600 milligrams. Next, if the patient begins to show signs of toxicity and the target concentration is decreased to 10 milligrams per liter, what would you need to do to get to this level? So basically, you're cutting the target concentration in half. So how do we get to the new level? Well, you stop the infusion for just 1 half-life. That's the meaning of half-life. You stop the infusion for 1 half-life, which is 10.5 hours, and the plasma concentration will decrease by half. Next, assuming 100% bioavailability, and again, they're either going to have to tell you that the drug is 100% bioavailable, or they're going to have to say the drug is given IV. And if it's an IV drug, you're going to assume it's 100% bioavailable. So, assuming 100% bioavailability, what oral dose of drug X would be necessary to maintain the new target level? So this is looking for a maintenance dose. Maintenance dose is equal to the concentration at steady state times clearance. Our new concentration at steady state is 10 milligrams per liter. They gave us the clearance in the question. It's 2 liters per hour. So the maintenance dose is 20 milligrams per hour. And the last one, if the patient has kidney disease and the clearance is reduced to 1 liter per hour, but the volume of distribution is unchanged, what effect will this have on loading dose and maintenance dose? So the loading dose is based upon the volume of distribution. And we're told that the volume of distribution is unchanged. So in this case, the loading dose does not change. But the maintenance dose is decreased because of the reduced clearance. So you have to decrease the maintenance dose, but you wouldn't change the loading dose. So that's it for now. I'll see you next time.
It's time for another warm-up review. Let's get going. Which portion of the brain is supplied by the anterior cerebral artery? So this is the medial surface of the cortex, down deep in the longitudinal fissure. This is where the motor and sensory cortex for the legs and feet are found. Your middle cerebral artery supplies the lateral surface of the cortex. This includes Broca's area, Wernicke's area, and also the motor and sensory cortex for the face, arms, and upper body. Next, what are the symptoms of normal pressure hydrocephalus? Well, normal pressure hydrocephalus causes a reversible form of dementia where you have expansion of the ventricles. Now, most of the time dementia is irreversible, but this is the one where you can actually treat and make better. Now, the mnemonic for the symptoms is wacky, wet, and wobbly. So a patient would have dementia, urinary incontinence, and ataxia. Next, A 76-year-old man who recently suffered a stroke is brought to the clinic by his wife. She says that he now shaves only on the right side of his face, and he eats off only the right half of a plate. When asked to draw a clock, he draws just the right half of the clock face. A lesion in which area of the brain is most likely responsible for these findings? So this is hemispatial neglect, where the patient is basically unaware of one side of his body or one side of his world. So this is usually due to a cortical lesion in the non-dominant parietal lobe, which in most people is the right parietal lobe. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to be talking about pharmacodynamics, which is the relationship between the drug concentration and the effect the drug produces at that concentration. Let's start with potency and efficacy. We're going to look at some of the graphs that are somewhat similar to the McAllis-Mitten graphs, but instead of talking about the action of each enzyme on the substrate, we're now talking about the action of the drug to produce some therapeutic effect. Efficacy is the maximal response or effect that a drug can produce. We have dose plotted on the x-axis, but we've plotted it on a logarithmic scale rather than a linear scale, and that gives the curve an S shape. Then, on the y-axis, we have percentage maximal response, that maximal effect that the drug can produce. Think about a blood pressure drug. You give a little dose and you might lower the blood pressure a little bit, like 2 points. But you give a big dose and you might lower the blood pressure a lot, maybe like 20 points. And at some point, there's a limit to how much you can possibly lower the blood pressure. Even if you give more and more and more of a drug, there's a limit to how much the blood pressure will drop. And that limit is the maximal effect. And the maximal effect is basically the efficacy. Then, drug B is a second blood pressure drug, with a curve that looks like this. Maybe drug A is able to lower the blood pressure a maximum of 20 points, but drug B can only lower the blood pressure by 14 points at most. So we would say that drug A has a greater efficacy than drug B. So efficacy is only talking about that maximal response or maximal effect, and it really says nothing about the dose given. Then potency is the amount of drug needed to achieve a given effect. So efficacy has nothing to do with the dose given, but potency is all about the dose that you're giving. I'm not going to go into detail about how exactly we calculate potency, but think back to our example of blood pressure drugs. It looks like we get the maximal effect at about 1 on this scale. Let's say that's 1 milligram, just as an example. Now, drug C has the same maximal effect. So what could we say about the efficacy? Both of these drugs are capable of achieving the same maximal effect. They both lower blood pressure by 20 points or whatever. So the efficacy of these two drugs is identical. They're both equally efficacious. But for drug C, you had to give a much larger dose to achieve that same maximal effect. It looks like you had to give something like 100 milligrams to lower the blood pressure by 20 points. So, drug A is much more potent than drug C. Drug A has a higher potency. How does adding an antagonist affect potency and efficacy? This is another 4 or 5 star topic, so be sure to know how you interpret these graphs. Here in red, we see a receptor agonist, and then you add a competitive antagonist to the system. This is somewhat similar to competitive and non-competitive enzyme inhibitors. We're not inhibiting the enzyme, we're antagonizing a receptor. But the basic concept is the same. If the agonist is acetylcholine stimulating a cholinergic receptor, then an example of a competitive antagonist would be atropine. So what happens when you add atropine to the system? How does that affect the dose-response curve of acetylcholine, the agonist? A competitive antagonist shifts the curve to the right. It takes a larger amount of the agonist to achieve the same response. So, does that change efficacy or potency? It changes potency. You still reach the same maximum effect, it just takes more agonist to do so. So in this graph, the red curve is the agonist by itself, and the green curve is where you've added a non-competitive antagonist. With a non-competitive antagonist, the maximum effect is lower, and you can't overcome the antagonist by simply adding more agonist. So in this situation, efficacy is decreased. In this graph, we're not looking at an antagonist, but rather something called a partial agonist. A partial agonist is a substrate that stimulates or agonizes the receptor, but not as strongly as a full agonist. So because it has a weaker agonist effect, the maximum response is lower, which means the partial agonist has a lower efficacy than a full agonist. But potency is independent. A partial agonist could be more or less potent than a full agonist. It can shift the curve to the right or to the left, independent of what it does to the efficacy. To demonstrate that, look at this graph. The green curve is the full agonist, and the orange and pink curves are two different partial agonists. With either of these partial agonists, the maximum effect is lower, so efficacy is lower. But with partial agonist A, the curve is shifted to the left, which means increased potency. At a dose of 1 milligram, the partial agonist gives you the response of 25 or 30% of the maximum, while the full agonist response is only about 5% of the maximum. For any given dose, the partial agonist gives you a bigger response, up to about 15 milligrams, and then the curve crosses because the partial agonist has a lower efficacy. With partial agonist B, the curve is shifted to the right, and potency is lower. For any given dose, the full agonist will give you a bigger effect. So with partial agonists, the efficacy is always lower, but the potency could be higher or lower. Now let's talk about drug safety and therapeutic index. There are two components to therapeutic index. You've got an LD50 and an ED50. LD50 is the dose of a drug that is lethal to 50% of people. LD is lethal dose. So it's the dose that is lethal to 50% of the population. ED50 is the dose that is effective for 50% of the population. So if you divide LD50 by ED50, that gives you therapeutic index. You can have a high therapeutic index or a low therapeutic index. Now, which is better? Safer drugs have a higher therapeutic index. So a high therapeutic index means that the drug is safer. Let's think about that mathematically. Look at the numerator. If LD50 is higher, that means it takes a higher dose of the medication to kill the patient, and that makes it safer, right? And then consider the denominator. If ED50 is small, that means a very, very small dose of the drug is going to be effective, and that's also going to increase your therapeutic index. So a high therapeutic index is good. You can have a high therapeutic index either when the lethal dose is very, very high or if the effective dose is very, very low. So what are some examples of drugs with a low therapeutic index, where the toxic dose is only a tiny bit higher than the effective dose? A student sent us a nice little mnemonic for these, which is some drugs with low therapeutic index, which stands for seizure drugs, digoxin, warfarin, lithium, and theophylline. These are all drugs that we have to monitor on a regular basis. Low therapeutic index means the effective dose is pretty close to the toxic dose. You should also be familiar with a therapeutic window, which just means the range of doses that drugs are both safe and effective. If a drug has a wide therapeutic window, that means there's a big gap between the effective dose and the toxic dose. A narrow therapeutic window means that the gap is pretty small and it's fairly easy to go from a nice safe therapeutic dose to a toxic dose. Now we're ready for the end of session quiz. So pause the video, answer those questions, and we'll go over them together. First question. An investigator has developed 2 new preparations for insulin. Both preparations can lower the blood glucose by a maximum of 100 milligrams per deciliter. It takes 16 units of insulin preparation A to lower the blood glucose by 100 milligrams per deciliter, and it takes 12 units of preparation B to lower the blood glucose by the same amount. Which insulin preparation has a higher efficacy, and which has a higher potency? Efficacy is the reflection of the maximal effect of a drug can produce. Both of these drugs will lower the blood glucose by the same amount. That means that both drugs have an equal efficacy. But for potency, you have to look at the amount of drug required to produce the same effect. And since it takes less of insulin B to achieve the same maximal effect, we say insulin preparation B has a higher potency. Next, your patient is taking experimental drug Z to lower his LDL cholesterol. When he is given the antagonist drug X, the potency of drug Z is decreased, but the efficacy is unchanged. Doubling the dose of drug Z is shown to overcome the inhibition by drug X. Is drug X a competitive or non-competitive antagonist of drug Z? If you can overcome the antagonist by adding more of the agonist, drug Z, then drug X must be a competitive antagonist. Remember, competitive antagonists will reduce potency, but they will not change the efficacy. Last one. Drug A has a therapeutic index of 10 to 1, while drug B has a therapeutic index of 2 to 1. Which drug would be considered safer? There are two ways to approach this. You can remember that therapeutic index is LD50 over ED50. So if drug A has a lethal dose of 10, say 10 grams, but drug B has a lethal dose of just 2 grams, and the effective dose is the same for both, in this case 1, then drug A is much safer. Or you can just remember that a high therapeutic index, it means the drug is safer. So 10 to 1 is a lot higher than 2 to 1, so again, drug A is safer. That's it for now. We'll see you next time.
It's time for another warm-up review. Let's get going. In which section of the brainstem is each of the cranial nerve nuclei located? So the nuclei for cranial nerves 3 and 4 are located in the midbrain. Cranial nerves 5, 6, 7, and 8 are located in the pons. Cranial nerves 9, 10, and 12 are located in the medulla. And the nuclei for cranial nerve 11 are going to be located in the spinal cord, which you can remember because cranial nerve 11 is the spinal accessory nerve. Next, which cranial nerve is responsible for each of the following actions? So first we have eyelid opening, that's going to be the ocular motor nerve, number 3. Taste from the anterior 2/3 of the tongue, that's going to be facial nerve, number 7. Head turning, that's going to be the spinal accessory nerve, number 11. Muscles of mastication, that's going to be the trigeminal, number 5. Balance is going to be the vestibulocochlear nerve, that's going to be cranial nerve 8. And then monitored carotid body and sinus chemo and baroreceptors, that's going to be the glossopharyngeal nerve, cranial nerve number 9. Next, which regions of the brain compose the limbic system? So that's going to be the amygdala, the septal nucleus, the mammillary bodies, the fornix, the hippocampus, and the cingulate gyrus. That's it for the warm-up. Let's get to that lecture now.
In this video, we're going to be talking about drug metabolism. This is where our bodies perform some kind of chemical reaction in the drug, which usually inactivates it. Or drug metabolism could actually activate the drug. Some medications are actually prodrugs, which just mean they're administered as inactive compounds, and when the body metabolizes them, they become active. But eventually, even those drugs are going to undergo further metabolism and become inactivated. There are two basic types of drug metabolism reactions, which we call phase 1 reactions and phase 2 reactions. Now, you don't have to go through both phase 1 and phase 2, and you don't have to go through them in order either. You can do a phase 2 reaction first, or some drugs only go through phase 1 or only go through phase 2. Phase 1 reactions are hydrolysis, oxidation, and reduction. These kind of reactions result in slightly polar, water-soluble metabolites, which are often still active. Occasionally, phase 1 will inactivate a drug, but sometimes phase 1 reactions can activate a drug and make it more potent, like converting a prodrug into the active drug. Sometimes phase 1 metabolism can actually make a safe drug toxic. For instance, methanol undergoes oxidation, which is a phase 1 reaction. It undergoes oxidation to become formaldehyde, which is even more toxic than methanol was to begin with. And then phase 2 reactions include things like methylation, acetylation, glucuronidation, or sulfation. These are all examples of conjugation reactions. Conjugation means that you're joining the drug to some other molecule, like adding a methyl group or adding an acetyl group, or you're conjugating the drug to glucuronic acid, or to sulfate, or maybe glutathione. All of these phase 2 reactions result in very polar, inactive metabolites that are easy to excrete in the urine. Those highly polar, hydrophilic molecules can't cross cell membranes very readily, which means they cannot be easily reabsorbed by the kidneys. They get trapped in the urine and then excreted. Both phase 1 and phase 2 reactions take place primarily in the liver and sometimes in the kidneys. A drug might go through phase 1 metabolism on the first pass through the liver and then go through phase 2 on the second pass. Or another drug might go through phase 2 on the first pass through the liver and then go through phase 1 on the second pass. Or it might go through both phases in one pass through the liver. It just varies from drug to drug. But in general, I want you to remember phase 1 reactions are hydrolysis, oxidation, and reduction. And they create a slightly polar molecule that is still active. In phase 2 reactions are conjugation reactions that create a very polar molecule that is inactive. There are 3 other quick bullet points that I want you to remember. First, cytochrome P450 enzymes generally perform phase 1 reactions. We'll come back to cytochrome P450 in a second, but remember, phase 1 equals P450. The second quick bullet point is that elderly patients typically lose the ability to do phase 1 metabolism first. But they can still do those phase 2 conjugation reactions like glucuronidation and acetylation and so on. The third bullet point is that some people are what we call slow acetylators. They just don't acetylate drugs very readily. What kind of reaction was acetylation? It's a conjugation reaction, a phase 2 reaction. That means these people are going to be slow to inactivate certain drugs. So if you keep dosing the drug normally, but the patient is inactivating that drug more slowly than expected, the drug is going to build up and the patient will have a higher than average drug level. So that patient, they're at higher risk for drug toxicity and the side effects. So again, slow acetylators have higher drug levels and more risk of toxicity. So even though most people have to take a drug twice a day, for instance, some people might only need to take it once a day or every other day. Cytochrome P450 is a family of enzymes that catalyzes a huge variety of reactions. Some of the P450 enzymes are involved in things like bile acid synthesis or steroid synthesis. And then some P450 enzymes are involved with drug metabolism. You'll see it abbreviated CYP or CYP, and then you'll see a number, a letter, and then another number. So for example, one of the most important enzymes that metabolizes a bunch of different drugs is called a CYP3A4. That's a cytochrome P450, family 3, subfamily A, form 4. There are about 12 different enzymes that metabolize 85 to 90% of the drugs that we use. CYP3A4 by itself metabolizes around 50% of drugs. So what difference does all of this make clinically? Well, if you give 2 drugs that are both metabolized by the exact same P450 enzyme, it will take longer for both of those drugs to be inactivated because there's only so much of the enzyme to go around. So if you give both drugs at the same time, you might have increased plasma levels, or you might have a prolonged action of one or both of the drugs. So that's where drug-to-drug interactions come from. And then, apart from drug-drug interactions, sometimes drugs and foods and even herbal supplements can either inhibit P450 enzymes or induce the expression of P450 enzymes. Since these P450 enzymes can be involved in either activating or inactivating drugs, inducing P450 could either increase the drug activity or reduce the drug activity. You can look it up and figure it out for any given drug interaction, but you can't just make a blanket statement. You need to be familiar with a few drugs that are most commonly implicated in inhibiting and inducing these P450 enzymes. Let's look at these in the study guide. First is a list of well-known drugs for inhibiting cytochrome P450. This is only a partial list, but these are some of the most common, most notorious ones. There are tons of different mnemonics out there to help you remember these. In the study guide, we use the mnemonic crack amigos. The first C is for ciprofloxacin. R is for ritonavir, which is a protease inhibitor. This is the class effect of the protease inhibitors that are actually designed to inhibit cytochrome P450. A is for amiodarone. The second C is for cimetidine. K is for ketoconazole. And then A in amigos is for acute alcohol use. Chronic alcohol use will actually induce P450, as we'll see in just a moment, but acutely alcohol will inhibit P450. M is for macrolides like erythromycin and clarithromycin. I is for isoniazid. G is for grapefruit juice. So again, it isn't just drugs that inhibit the drug metabolism. Diet and supplements can do it too. O is for omeprazole. S is for sulfonamides. Sulfonamides can cause a lot of side effects, but they can also inhibit cytochrome P450. Another mnemonic we like to use is pick eggs. The P is for protease inhibitors. The I is for isoniazid. The C is for cimetidine. The K, ketoconazole. E, erythromycin. G, grapefruit juice. And S is for sulfonamides. Then, on number 5 in the study guide, we have the P450 inducers. Here's the mnemonic for those. Guinness, Coronas, and PBRs induce chronic alcoholism. So first of all, the G in Guinness is for griseofulvin, which is an antifungal drug. The C in Coronas is for carbamazepine, which is a seizure drug. Then, PBRs in this case does not stand for Pabst Blue Ribbon. The P stands for phenytoin, another seizure drug. B for barbiturates, and R for rifampin. And then make sure that you're making these plural. It's PBRs, because the S is for St. John's wort, which is an herbal supplement that is supposed to help treat depression. And then, if a patient decides to start taking St. John's wort on its own and doesn't tell you about it, this can induce his P450 enzymes and mess with the drug levels in lots of different medications. So again, Guinness, Coronas, and PBRs induce chronic alcoholism. Because this tells you these drugs induce P450. It also helps you to remember that chronic alcoholism will induce P450s. But remember, like we said, acute use of alcohol will actually inhibit P450 enzymes. Another mnemonic we like to use for inducers is BCG PQRS. The B is for barbiturates, the C for carbamazepine, the G is for griseofulvin, the P is for phenytoin, Q, quinidine, R, rifampin, S for St. John's wort, and also chronic alcohol use. Let's do a quick review to make sure you have those two lists down. This is a little game called inducer or inhibitor. Carbamazepine, that's an inducer. Clarithromycin, inhibitor, it's a macrolide. What about the two anti-TB drugs? Rifampin, inducer, and then isoniazid, inhibitor. And the antifungals, griseofulvin, inducer, ketoconazole, inhibitor. Two drugs to suppress stomach acid. Omeprazole is an inhibitor. Cimetidine, also an inhibitor. What about the two things that patients might not tell you about unless you ask? Grapefruit juice, inhibitor. St. John's wort, inducer. And some drugs commonly used for UTIs. You've got Bactrim, inhibitor because it's a sulfonamide. Ciprofloxacin, inhibitor. Chronic alcohol use, inducer. And acute alcohol use, inhibitor. What kind of metabolism reactions do we say P450 enzymes catalyze? Phase 1 or phase 2? It's phase 1. And finally, list 3 types of phase 1 reactions: hydrolysis, oxidation, and reduction. Okay, let's talk about the metabolism of ethanol. I'm sure you know that the organ that's primarily responsible for metabolism alcohol is liver, and there are two key enzymes that you need to remember. There's an enzyme called alcohol dehydrogenase that converts ethanol to acetaldehyde, and then an enzyme acetaldehyde dehydrogenase which converts acetaldehyde to acetate. Pretty easy. Both of those enzymes are dehydrogenases, so they dehydrogenate. They remove hydrogen. And you have to do something with those hydrogens you're removing. So these enzymes transfer the hydrogen to NAD, which is the active form of niacin. That NAD is a cofactor, and that cofactor is the limiting reagent in alcohol metabolism. So you need to know the drugs that inhibit each of these enzymes. The first enzyme, alcohol dehydrogenase, is inhibited by a drug called famotidine. Famotidine is used to treat methanol poisoning and ethylene glycol poisoning. The second enzyme, acetaldehyde dehydrogenase, is inhibited by a drug called disulfiram, which we use to treat alcoholism. So let's talk about famotidine for just a second. Methanol and ethylene glycol are both metabolized by alcohol dehydrogenase. Methanol is a wood alcohol, and occasionally alcoholics might try to get drunk on methanol. But remember, we said that instead of getting metabolized to acetaldehyde, methanol gets metabolized to formaldehyde, which is toxic. It can cause acidosis, it can cause retinal damage and blindness, and even in relatively small doses, like 15 cc's or half a shot. So it is very dangerous. If you drank a whole bottle of methanol, you'd die. To treat methanol poisoning, we want to prevent the metabolism of methanol to formaldehyde. So we want to inhibit this enzyme, alcohol dehydrogenase. So if we give a patient famotidine, it will inhibit alcohol dehydrogenase and prevent formation of formaldehyde. You could also give the patient a bunch of ethanol, and basically ethanol competes with methanol for the enzyme, and it slows down that formaldehyde formation. Or you could do dialysis to remove the methanol. We also said that you could use famotidine to treat ethylene glycol poisoning. Ethylene glycol is antifreeze, right? Well, people don't get drunk on antifreeze, but apparently it does taste pretty sweet, so kids and pets will sometimes drink it if they find it. So when you drink a nice antifreeze cocktail, the ethylene glycol gets metabolized to oxalic acid and other organic acids, which again cause acidosis. A high anion gap metabolic acidosis. If you remember the mnemonic mud piles for the causes of high anion gap metabolic acidosis, the M in mud piles is for methanol and the E is for ethylene glycol. So ethylene glycol causes metabolic acidosis, and it can also lead to kidney damage, CNS problems, and heart and lung toxicity. Especially remember that kidney damage, because the oxalic acid precipitates out as calcium oxalate crystals in the urine. And again, you can prevent this by giving famotidine to inhibit alcohol dehydrogenase, or by giving alcohol to compete for the enzyme. So that's the first enzyme. But what about the second enzyme, which is acetaldehyde dehydrogenase? We said that you could inhibit that one with a drug called disulfiram. And we said we could use that to treat chronic alcoholism. Actually, we use disulfiram to discourage alcoholics from drinking. Say you have an alcoholic in recovery and you give him disulfiram. Well, that will inhibit the acetaldehyde dehydrogenase, and if the patient relapses and starts drinking, the acetaldehyde will build up in his body. That'll cause flushing and sweating, headaches, nausea, vomiting, and hypotension. The patient will definitely not be going back to alcohol because they think it's going to make them that sick. You should also know a handful of other drugs that can cause disulfiram-like reactions, like metronidazole, which is the most important one, certain cephalosporins, procarbazine, which is a cancer drug used to treat Hodgkin lymphoma, and first-generation sulfonylureas like tolbutamide, which nobody ever uses anymore. So if you start somebody on one of these drugs, for instance, you start a patient on metronidazole for diverticulitis or something, you really need to tell that patient to avoid alcohol while they're taking it, because it might make them sick. Now it's time for the end of session quiz, so answer those questions and I'll go over the answers. Let's go through these. First question. Which hepatic phase of metabolism is lost first by geriatric patients? That's phase 1. Which phase is mediated by cytochrome P450? That's also phase 1. Next question. What medication inhibits acetaldehyde dehydrogenase? That's disulfiram. Next. What medication inhibits alcohol dehydrogenase? Someprazole. Next, list 7 inducers of cytochrome P450. For the inducers, our mnemonic was Guinness, Coronas, and PBRs induce chronic alcoholism. Or you could use BCG PQRS. That stands for griseofulvin, carbamazepine, phenytoin, barbiturates, rifampin, St. John's wort, and chronic alcoholism. Now, list the 11 inhibitors of cytochrome P450. For the inhibitors, our mnemonic was crack amigos or pick eggs. These stand for ciprofloxacin, ritonavir and other protease inhibitors, amiodarone, cimetidine, ketoconazole, acute alcohol use, macrolides, isoniazid, grapefruit juice, omeprazole, and sulfonamides. That's it for now. We'll see you next time.
I don't always get methanol poisoning, but when I do, I prefer fomeprazole. Stay thirsty, my friends.
It's time for another warm-up review. Let's get started. Complete the following diagram of the cell cycle. So right after mitosis, the cell goes into interphase, which includes G1, and then there is S phase, and then G2, and then back to mitosis, or sometimes referred to as M phase. That's it for the warm-up. Let's get to that lecture now.
In this video, we're going to talk about drug elimination. And I'm not talking about when your mom knocks on your door and you hide your stash under the bed or chuck it out the window. This isn't high school anymore. I'm talking about how we eliminate drugs from our bodies. We talked about how our bodies metabolize drugs in another video, and now we're talking about how we get those drugs out of the body. When you give a patient a dose of a drug, you know the drug's effect will only last a certain length of time. Eventually, the body will inactivate the drug and then eliminate it. That's why you have to keep giving the drug every day, or twice a day, or however it's dosed. So we need to start by talking about elimination kinetics, which determines how quickly we're able to eliminate the drug. There's zero-order elimination and first-order elimination. We touched on this when we talked about the Michaelis-Menten enzyme kinetics. Zero-order elimination is where a constant amount of drug is eliminated per unit of time. Basically, it behaves as though the enzymes are saturated. It doesn't matter how much of the substrate there is. It doesn't matter what the concentration of the substrate is. The enzymes available to eliminate the drug can only work so fast. So it's basically saturation kinetics. No matter how much drug is in the system, it can only be eliminated at a particular rate. So if a drug is eliminated at 25 milligrams per hour, regardless of the drug concentration, that's zero-order elimination. Make sure you can identify that term. Another way to say it is that zero-order kinetics in the plasma concentration decreases linearly with time. So if you start out with a plasma concentration of 100 milligrams per liter, or whatever, and the zero-order elimination rate is 25 milligrams per hour, after 1 hour, the drug level would go from 100 to 75. And then after another hour, it would go from 75 to 50, and then 50 to 25, and then 0. So after 4 hours, in this example, the drug would be completely gone. There are 3 examples of drugs that are metabolized this way, using zero-order kinetics: phenytoin, ethanol, and aspirin. At least at toxic concentrations, aspirin is metabolized at a constant rate, using zero-order elimination. So you can remember the mnemonic P, P-E-A, and a P is round like 0. So definitely know phenytoin, ethanol, and aspirin. And then there's first-order elimination. This is where a constant proportion or constant percentage of the drug is eliminated per unit of time. Zero order was a constant amount per hour, but first order is a constant percentage per hour. This means that the plasma concentration decreases not linearly, but exponentially with time. In other words, instead of eliminating a constant 25 milligrams per hour or whatever it was, like we saw in zero order kinetics, with first order, you're going to eliminate a fixed percentage or proportion of the drug. So you might clear 50% of the drug out every hour. So the absolute amount of drug eliminated will vary, but the proportion eliminated will always be the same. So if you start out with the same plasma concentration of 100 milligrams per liter, and you're eliminating 50% of the drug every hour, that first hour you'll eliminate 50 milligrams. The second hour you'll eliminate 50% of whatever is left. So then you'll go from 50 to 25. And then in the third hour you'll go from 25 to 12.5. And in the fourth hour, you go from 12.5 to 6.25, and so on. So with these numbers, after 4 hours of zero order elimination has gotten you to a plasma concentration level of 0. But with first order elimination, there's still a little bit of the drug left. So in this example, zero order clears the drug faster. But what if you'd started with a concentration of 500 milligrams per liter? With first order elimination, still clearing about 50% of the drug per hour, you'd be at 250 milligrams after the first hour, and then 125 milligrams after 2 hours, 62.5 after 3 hours. You don't always eliminate 50% in an hour, that's just the example we're using. But if you had a starting concentration of 500 milligrams and the drug was eliminated using zero order kinetics, and say it was still clearing at 25 milligrams per hour, what would the level be after 3 hours? Well, you started with 500, you cleared 25 each hour, so after 3 hours that would leave you with a level of 425 milligrams. So you can see that in this example, starting with a higher plasma concentration, first order elimination clears the drug much, much faster. After a drug has been metabolized and inactivated, there are two main routes to get the inactive metabolites out of the body. You're either going to dump those inactive metabolites into the bile and excrete them in the feces, or you'll dump them in the urine. Renal elimination is a very, very common way of getting drugs out of our body. So let's talk about how the pH of urine can influence drug elimination. The first thing you need to know is that polar charged ionic species get trapped in the urine. Why is that the case? Ions don't cross through the plasma membrane very easily, right? Ions are hydrophilic, but our plasma membranes are lipid bilayers, right? So uncharged neutral lipophilic molecules that get filtered in the glomerulus and end up in the filtrate can pass through the membranes of the proximal tubules and be reabsorbed. But those hydrophilic ionized species get trapped in the filtrate and pass right through the nephron into the collecting system. So when we talk about ionic species, we're mainly talking about drugs that are weak acids and weak bases. Let's look at this in your study guide. Weak acids dissociate into hydrogen ions and an anion. Weak bases start out with a positive charge, and they dissociate into a hydrogen ion and an uncharged base. So pay attention to where the charged and uncharged forms are. This is pretty basic stuff. Not basic like alkaline, just elementary. I'm just giving you some background before we start talking about how this affects drug elimination. One of the other basic, elementary, fundamental pieces of information that you need to know is pKa. So what is pKa? That's the first bullet in your study guide, below the acid-base equations. pKa is the acid dissociation constant. The pKa is the pH at which the amount of a non-protonated form of the drug equals the amount of the protonated form of the drug. So at whatever pH the two sides of the equation are balanced, where the amount of acidic drug is equal to the amount of anions, that's the pKa. Or, if you're dealing with a basic drug, it's the pH where the amount of basic drug is equal to the amount of uncharged base. So that's the pKa. The acid dissociation constant. It's a pH value, and every drug has its own pKa, which you could look up if you needed to. The second bullet says, if the pH is low in an acidic environment, And more importantly, if the pH is less than the pKa for that substance, there will be more of the protonated form. When the pH is at the pKa value, the protonated and non-protonated forms are equal. But when the pH is lower than the pKa, the low pH means more acid, and there are more protons around, and those protons are going to bind to the anion and help tip the scale toward the protonated form. So this means that when the urine pH is low, if you have acidic urine, both acidic drugs and basic drugs are shifted toward the protonated form over here on the left. So which type of drug is going to be trapped in that acidic urine? The basic drugs, because the protonated form of that basic drug is the charged form. And we started out by saying that charged ionic species get trapped. So in acidic urine, the drugs that are weak bases will be trapped. But acidic drugs, when they're protonated, they're not charged. So the basic drugs will get trapped in the acidic urine. Those basic drugs can't cross through the plasma membrane anymore, so they stay in the urine and get excreted, while the acidic drugs can be reabsorbed into the body. The third bullet says that if a pH is high, which would mean basic environment, and more importantly, if the pH is higher than the pKa, then there will be more of the non-protonated form. So when the pH is high and you don't have as many protons around, the equation shifts toward the right so that your weak acids will have a charge and your weak bases will be uncharged. And that means that in the basic alkaline urine, acidic drugs, the charged ones, are going to be trapped and excreted out, but basic drugs will be reabsorbed. Now, why is this important? Look at the next two bullets. In order to treat an overdose of acidic drugs, such as aspirin, which is salicylic acid, in order to treat an aspirin overdose, you're going to use sodium bicarbonate. Again, you can treat an overdose of acidic drugs with sodium bicarb. That bicarb is going to be excreted into the urine, and then the urine becomes alkaline. And what did we just say happens to weak acids in a basic environment? Those weak acids are going to be trapped. And that's how you can get rid of acidic drugs like aspirin. You trap it in the urine by giving a base like sodium bicarb to alkalize the urine, and then it traps the acidic drug there. When the aspirin is trapped in the urine, it can't be reabsorbed, and then you can urinate it out. Now, don't get confused. You might think, well, if I give IV bicarb, I'm going to alkalize the serum, and then the aspirin is trapped in the serum. That's not what happens, because the body will concentrate the bicarb in the urine, so the drug gets trapped in the urine, and it's a much more important principle there. Then the last bullet says, to treat overdoses of basic drugs like amphetamines, you acidify the urine by giving ammonium chloride. So ammonium chloride acidifies the urine and traps those basic drugs in the acidic urine. So you give bases to help eliminate acids and acids to help eliminate bases. So that's pretty much it for drug elimination and urinary pH. Next, we're going to go over something that really has nothing to do with drug elimination, but we've got a little extra time in this video. These drug suffixes are great to know because they can help you identify a lot of drugs very quickly. If you know these, you may be able to identify what a drug does based on the suffix. And if you're not that familiar with that particular drug name, this can really come in handy. In your study guide, there's an enormous table with about 35 suffixes that I think it's worth your time to learn. I'll bet you know a bunch of these already. Some of these are listed in your review books, but a lot of them aren't, so let's just go through the study guide. The first one is AFO, which are phosphodiesterase inhibitors, the erectile dysfunction drugs. Sildenafil is one example, and that's Viagra. Another one is tadalafil. Azepam is a suffix for benzodiazepine, like lorazepam or diazepam. Azines are the phenothiazines. Some of the phenothiazines can be used as neuroepileptics, like chlorpromazine or thioridazine, and then other phenothiazines are used as antiemetics, like promethazine. Azalam is another suffix for benzodiazepine, such as alprazolam or midazolam or triazolam. So azalam and azepam are both benzos. Drugs that end in barbitol are barbiturates like phenobarbital and secobarbital. Bendazole are antiparasitic drugs like mebendazole or albendazole, which are used for worm infections like helminth infections. You can think about how worms are bendy, and you can use bendazole to treat those. Cane are the local anesthetics like lidocaine and tetracaine. The next one is col. If you see col, you'll know it's a cholinergic agonist like muscarinic agonists like bethanacol or carbachol. Cillin are the penicillins like amoxicillin or methicillin. Conazole are antifungals like fluconazole or ketoconazole. The chemical class in these is called imidazole, and lots of people call these azole, antifungals, to distinguish them from other antifungals like nystatin or amphotericin. But the problem with calling them azoles is that there are other drugs in an azole, like metronidazole, which is an antibiotic, not an antifungal. And there's mebendazole, which, like we just mentioned, is used for worm infections. But if you see conazole, definitely antifungal. The next two are curium and curonium. And these are non-depolarizing neuromuscular blocking agents, like atacurium or vecuronium or rocuronium. Rocuronium always sounds so cool. It's kind of like a radioactive hair metal band. Rocuronium. The cyclines are a type of antibiotic that inhibit protein synthesis, like tetracycline or doxycycline. Dipene are calcium channel blockers, specifically dihydropyridine calcium channel blockers like nifedipine or amlodipine. Dronates are the bisphosphonate drugs used to treat osteoporosis, like alendronate or risandronate. Teens are SSRI antidepressants like fluoxetine, which is Prozac, and paroxetine and sertraline. Fluorine are the inhaled anesthetics like isoflurane and sevoflurane. Gliptins are DPP-4 inhibitors, which are a class of drugs used to treat type 2 diabetes. The examples of these drugs would be sitagliptin and saxagliptin. Glitazones are also diabetes drugs. Glitazones and thiazolidinediones, or TZDs, which increase insulin sensitivity. These are pioglitazones and rosiglitazone. Ipramine are tricyclic antidepressants like chlormipramine or imipramine. MAB is actually an acronym for monoclonal antibody. Whenever you see a MAB at the end of a name, that's a monoclonal antibody. Infliximab or rituximab would be a couple of examples. The next one is mustine. Mustines are nitrosoureas, which are cancer drugs. These are drugs that readily cross the blood-brain barrier and treat brain tumors. Also, because they cross the blood-brain barrier, they can cause CNS side effects. That makes sense. Navir are protease inhibitors used to treat HIV, like ritonavir or sequinavir. These would be a couple examples of the long list. Remember, we said in the last video that these are also cytochrome P450 inhibitors. Olol are beta blockers like atenolol or metoprolol. And remember, there are two exceptions to this olol suffix, which are carvedilol, which ends in ILOL, and labetalol, which ends in ALOL. These are beta blockers that also block alpha receptors, so the different spelling might help you to remember they have a slightly different function. Operadol are another type of neuroleptic, like haloperidol and droperidol. We said that azine was a suffix for phenothiazine neuroleptics, like chlorpromazine. Well, haloperidol is a different chemical class of neuroleptics. Phyllin are the methylxanthines like theophylline or aminophylline. Pril is the ACE inhibitor, like enalapril or lisinopril. Prost is the prostaglandin analogs. These are for drugs like latanoprost or travoprost, which are used to treat glaucoma. The next one is sartan. These are the angiotensin II blockers like losartan and valsartan. Statins are HMG-CoA reductase inhibitors used to lower LDL levels, like atorvastatin or simvastatin. Stigmine is an anticholinesterase inhibitor, the so-called indirect cholinergic agonist, like neostigmine and physiostigmine, and also rivastigmine, which we use to treat Alzheimer's disease. Sterol is a beta-2 agonist like albuterol or salmeterol. Tadine are histamine antagonists, H2 blockers like cimetidine or ranitidine. Triptans are drugs like sumatriptan, which you might know better as Imitrex. These are serotonin agonists, serotonin 1B, 1D agonists, which are used to treat migraines. Triptylin is another group of tricyclic antidepressants. Amitriptyline and nortriptyline would be examples. So TCAs can either end in ipramine or triptyline. Tropin are pituitary hormones like somatotropin. And the last one is Zosyn, which are the alpha-1 antagonists like prazosin and doxazosin. Whew, I know that's a huge list, and I know that students can find these drug names and classes really very frustrating. It's like learning a foreign language. But I would strongly recommend that you make some flashcards and learn these. Be able to match the drug with its class or its action based on its name. It'll really help you, especially when you get into the hospital and in the clinic. Now we're ready for the end of session quiz. So I want you to pause the video and work through those questions, and then we'll go over the answers together. First question, which medication overdose can be treated with sodium bicarbonate? You use bicarb to alkalinize the urine, which is going to trap weak acids. So you use sodium bicarb to treat overdoses with weak acids like aspirin. Which medication overdose can be treated with ammonium chloride? This is going to acidify the urine and trap weak bases. So this is used for treating overdoses of drugs that are weak bases, such as amphetamines. To what class do each of the following belong to? So these are all suffixes that we just finished discussing, but we didn't list any of these specific drugs. So I'm hoping you'll be able to recognize these are all drugs that act on the autonomic nervous system. So hopefully this is a little bit of a review for you. Methacholine. That's a cold drug. That's a cholinergic drug, a muscarinic agonist. Propranolol. Olol is a beta blocker. Proteostigmine. Stigmine is an anticholinesterase. Formoterol. Turol is a beta-2 agonist. Formoterol is actually a long-acting inhaled beta-2 agonist. And terazosin is a Zosyn drug, an alpha-1 antagonist. All right, that's it for this video. We'll see you next time.
Let's take a look at the warm-up. First question, what regulates the progression of the cell cycle from G2 phase to M phase? Well, that's the tumor suppressor P53. Next, the complexes of cyclin D plus CDK4 and cyclin E plus CDK2 assist in the progression of the cell cycle into which phase? Well, they assist in the progression of G1 to S phase. And the last question, the complexes of cyclin A and CDK2 and cyclin B and CDK1 assist in the progression of the cell cycle into which phase? These assist in the progression of the G2 phase to M phase. Now we're ready to get started with the lecture.
Hello everyone and welcome to our Step 1 video on drug side effects. Now Pharm can be a little dry because sometimes you just have to memorize a list of drugs. Now today we're going to try to make that a little less painful. We're going to group these drugs together by side effect. So we won't be going drug by drug, we'll be going side effect by side effect. Now we'll also have some clinical vignettes to start off each section so you can get an idea of how you might see these on your test, and we'll also throw in a few game shows to help with retention as well. So first we'll start with cardiovascular side effects. And our first vignette is here. A 34-year-old man in the hospital is being treated for a severe methicillin-resistant Staph aureus osteomyelitis when he develops a full-body cutaneous flushing. So what's causing the flushing here? Well, when you hear MRSA, you almost always think about the drug vancomycin as the treatment. Now, this is red man syndrome. So remember, this isn't actually a drug allergy. You just have really just to slow down the infusion and pre-treat with antihistamines if you're going to restart that vancomycin. Now, what else can cause flushing? The other important one to remember is niacin. Niacin can cause a cutaneous flush. Adenosine, though not used quite as often as some of these other medications, is a very potent vasodilator as well, so it can cause cutaneous flushing as well. The dihydropyridine calcium channel blockers can also cause this by smooth muscle relaxation, but you don't see that quite so often. Next, we have coronary vasospasm, and that can be caused by cocaine. Along with cocaine, some of the other illicit drugs, amphetamines, methamphetamines, can cause coronary vasospasm. Your triptan drugs, like sumatriptan and ergotamines, can cause that coronary vasospasm. Those are treatments for migraine headaches. This doesn't happen very often, but we generally don't give triptans to patients with coronary artery disease or strokes either. Next, we have dilated cardiomyopathy. So this is potentially associated with doxorubicin and daunorubicin. So these are anti-cancer drugs. Next, we have torsades de pointe. So this is a twisting of the points, that sinusoidal wave pattern that you can see on your ECG. Drugs that prolong the QT interval are going to increase the risk of torsades. And so these include the class 3 antiarrhythmics, which are your potassium channel blockers. Also the class 1A antiarrhythmics, which are a category of your sodium channel blockers. Other drugs that prolong the QT interval include the macrolides. Think of haloperidol, which is an antipsychotic, chloroquine, which is an anti-malarial drug, and then the protease inhibitors for HIV. So let me go through those again. Potassium channel blockers, class 1A sodium channel blockers, macrolides, haloperidol, chloroquine, and the protease inhibitors. And what was the treatment of choice for torsades? That's going to be, you're going to push IV magnesium. Let's move on to hematology. So our vignette here, a 44-year-old woman is in the hospital for a deep venous thrombosis of her right lower leg. After several days of treatment, her platelet count drops to 30,000 per microliter. This one is going to be actually pretty easy. So what are you going to do the treatment generally? That thrombocytopenia can result from administration of heparin. And it actually has its own acronym, HIT, heparin-induced thrombocytopenia. What else can cause this? Cimetidine. So cimetidine is a H2 blocker. We don't use it that often anymore. And then another medication, again, for that thrombocytopenia. Now next we have agranulocytosis. In agranulocytosis, you're going to have the 3 C's. You got to think about clozapine, carbamazepine, and colchicine. You also have your antithyroid drugs, so propylthiouracil and methimazole. And then you also have dapsone. That's another one. So let's go through those again. The 3 C's, clozapine, carbamazepine, colchicine, the 2 antithyroid drugs, propylthiouracil and methimazole, and then the final drug is going to be dapsone. All these drugs are going to call agranulocytosis. Next, we have aplastic anemia. What can be as a result of that? It's going to be chloramphenicol, benzene, the NSAIDs, propylthiouracil, also known as PTU, methimazole is going to go in there as well. All are going to cause aplastic anemia. Next, we have gray baby syndrome. That's going to be caused by chloramphenicol. So this is a toxic accumulation of the toxic chloramphenicol metabolites. And this occurs in infants because that UDP glucuronol transferase enzyme is immature. And it's actually unable to metabolize that drug very well. So babies are going to vomit. They're going to have kind of an ashen gray color, hence the name. Limp muscles, hypotension, cyanosis, and cardiovascular collapse. Next, we have hemolysis in G6PD deficient patients. So we got to remember isoniazid, sulfonamides, primaquine, aspirin in very high dosages, ibuprofen, nitrofurantoin, that's a UTI drug, then also dapsone, favamines, and naphthalene. So all of these drugs can cause hemolysis in a G6PD deficient patient. Next, we have thrombotic complications. This might seem a little vague, but what I want you to think of is oral contraceptive pills, especially if you have a patient who's a smoker and over the age of 35. They end up with a clot, think of OCPs. Okay, so let's see what we remember with our first game show. Remember, yell out the answer, especially if you're in the library. First one here, daunorubicin, doxorubicin. The answer is dilated cardiomyopathy. Next, macrolides, haloperidol, chloroquine, that's torsades de pointe. Next we have clozapine, carbamazepine, colchicine, a lot of C's there, that makes you think of agranulocytosis. An easy one, chloramphenicol, that's the only one that's going to cause gray baby syndrome. Next we have vancomycin and niacin, think of flushing. Next we have heparin and cimetidine, think of thrombocytopenia. Next we have respiratory. Our vignette here, a 56-year-old man presents with slowly worsening shortness of breath over the past several months. He denies cough, fever, or any other ill-like symptom. He has a past medical history of atrial fibrillation. The answer here is amiodarone. Amiodarone is often given to patients with AFib, and a very important side effect is pulmonary fibrosis. Now remember, with amiodarone, you have to check your PFTs, your LFTs, and your TFTs. Now other medications that can cause pulmonary fibrosis include bleomycin and busulfane. Now those two are just anti-cancer drugs. Next one we have here is a cough. So the ones you want to think about here, ACE inhibitors. ACE inhibitors can cause a chronic cough, and the mediator of that is bradykinin. Remember, so bradykinin is in excess causing that cough. ARBs, the angiotensin receptor blockers, actually don't cause that increase in bradykinin, so they're often a substitute for ACE inhibitors when patients get that cough. Let's move on to GI. So here we have a 32-year-old woman presents with several days of worsening watery diarrhea and abdominal pain. About 2 to 3 weeks ago, the patient was ill with a sore throat for which she received treatment. What does she have? So this is probably pseudomembranous colitis, and what causes this? Well, any antibiotic can actually cause it, but the two that we get the most test questions are going to be clindamycin and then amoxicillin or ampicillin, very similar medications there. This patient likely got something like amoxicillin for strep throat. Next, we have hepatic necrosis. So this can be seen with excess halothane, excess acetaminophen, valproic acid, and then Amitina phalloides, which is a mushroom toxin. Next, we have just plain Jane hepatitis. A million things can irritate the liver, but the one I really want you to remember here is INH, isoniazid. Now let's move on to endocrine. A 66-year-old man presents with a progressive enlarging breast tissue. He has a past medical history of congestive heart failure. What's the drug? So this patient might be on something like spironolactone for the CHF, and though it occurs much less often, also digoxin has that potential to cause gynecomastia as well. Now other things that cause gynecomastia include estrogens, cimetidine, chronic alcohol use, ketoconazole, and then marijuana use as well. So there are a couple of decent mnemonics for these drugs that cause gynecomastia. And naturally both of them are a little PG-13 and sexist. The old standard is the mnemonic, some drugs cause awesome knockers, and that's going to stand for spironolactone, digoxin, cimetidine, alcohol, specifically chronic alcohol use, and then that K is for ketoconazole. And then a student from Temple sent us another one that he came up with, stacked, S-T-A-C-K-E-E-D. Pretty similar list. So the S is for spironolactone, T for THC, so marijuana again. A is for alcohol, C is for the H2 blocker cimetidine, K again for ketoconazole. The E is for estrogens, which should be pretty obvious that if a man is taking a bunch of estrogens, then that could lead to some breast development. And then D is for digoxin again. Moving on to hot flashes. So this can be caused by tamoxifen or clomiphene. So these are the SERMs, so the selective estrogen receptor modulators. Next, we have hypothyroidism. That can be caused by amiodarone. Remember, we're checking our TFTs with amiodarone. It can also be caused by lithium and sulfonamides. Okay, it's time for that game show number 2. Let's get going. So the first one here, amiodarone, bleomycin, busulfan. The answer is going to be pulmonary fibrosis. Next, we have spironolactone, estrogens, ketoconazole. That's going to be gynecomastia. Next, we have clindamycin, amoxicillin, ampicillin. Think of pseudomembranous colitis. Next, we have lithium, sulfonamides, amiodarone. That's going to be hypothyroidism. Next, we have halothane, excess acetaminophen, valproic acid. That's going to be hepatic necrosis. Let's go to our musculoskeletal section. Here's our vignette. A 50-year-old man presents with a swollen, red, and painful right first toe. This began spontaneously. He has a past medical history of diabetes, hypertension, and dyslipidemia. What meds are we thinking here? So, well, he's likely got gout, so you need to remember that the diuretics like loop and even thiazide diuretics can exacerbate gout. The one you may not have thought of for this patient is niacin. Maybe he has some low HDL, he might be taking niacin for that. It doesn't just cause flushing, it can actually worsen gout as well. Other drugs that include cyclosporin and pyrazinamide. Next, we have gingival hyperplasia. Now, classically, we think about phenytoin with this one, but also think about verapamil. Verapamil can also be associated with gingival hyperplasia. Next, we have osteoporosis, corticosteroids, and heparin. So you definitely want to monitor your patients with chronic rheumatologic diseases that are using those corticosteroids regularly. They're going to very quickly get osteoporosis. Next, we have photosensitivity. Think of sulfonamides, amiodarone, tetracycline. They can all cause a photosensitivity. Remember that there's a mnemonic that's been around forever, SAT for photo, to help you remember photosensitivity. Next, we have Stevens-Johnson syndrome. Remember, this includes seizure drugs, sulfonamides, and penicillins. Those are the general rules. And so your seizure drugs are going to include ethosuximide, carbamazepine, lamotrigine, phenytoin, phenobarbital. The one outlier that doesn't fit into this situation is allopurinol. That's another drug that can cause Stevens-Johnson syndrome. So remember, seizure drugs, sulfonamides, and penicillin. There's another mnemonic that you can use to kind of help you with this one, clappers, and that's with 3 Ps. So the C is carbamazepine, L lamotrigine, A is for allopurinol, P for phenytoin, P for phenobarbital, P for penicillin, and then E for ethosuximide. The R actually doesn't have a drug. It's just to remind you of rash. And then S is for sulfa drugs. Next, we have lupus-like syndrome or drug-induced lupus. So the mnemonic here is SHIP. So S is for sulfonamides, H is for hydralazine, I is for isoniazid, P is for procainamide, and then the other P is for phenytoin. Next, we have tendinitis, tendon rupture, and cartilage damage that can be associated with fluoroquinolone. So you might get a question about a runner who gets Achilles tendon tenderness while taking ciprofloxacin or maybe levofloxacin for something like a UTI or sinusitis or pneumonia. All right, so now let's move on to renal. Here's our vignette. A 27-year-old woman presents with fever, dysuria, and lower back pain. Her labs show a creatinine of 2.5, eosinophiliuria, and urine white cell casts. She has a past medical history of hypertension and chronic lower back pain. What do you think here? So it's not a slam dunk diagnosis, but this patient has interstitial nephritis. She may be taking NSAIDs for her chronic back pain, but also think about furosemide for her hypertension. Antibiotics are also a very common cause of interstitial nephritis. Next, we have diabetes insipidus. This can be caused by lithium and dimethylcycline. Now, what can we use to treat nephrogenic diabetes insipidus? Well, you can use hydrochlorothiazide. That's a very commonly used one. Amiloride is another one that you can use first line. Next, we have Fanconi syndrome. So this is a proximal tubular defect. And if the proximal tubules are not working, then you're going to spill all kinds of stuff into your urine that you should be reabsorbing. So this can be associated with expired tetracycline. It can also be associated with heavy metal exposure as well as Wilson's disease. Next, we have hemorrhagic cystitis. So this is associated with cyclophosphamide and ifosfamide. Moving on to neuro, here's our vignette. A 58-year-old man presents with new onset tremors in his hands. He has a past medical history of diabetes, hypertension, and chronic nausea. This one is a little bit vague. So this patient might have gastroparesis due to that diabetes and getting that chronic nausea. And for that problem, we often use metoclopramide. And that's going to improve that gastric emptying. Now, metoclopramide can cause a Parkinson-like syndrome. Other drugs include things like the antipsychotics and then reserpine. Synchonism. So first, you gotta know what synchonism is. So synchonism is dizziness with headache, vision changes, and tinnitus. Again, so dizziness with headache, vision changes, and then tinnitus. That's going to be synchonism. And it can be caused by the cues. So quinidine, which is a class 1A antiarrhythmic, or quinine. So quinidine and quinine are causing synchonism. Next, we have seizures. So this can be associated with bupropion. So if you have someone that maybe you're going to put on bupropion for smoking cessation or maybe for depression, you need to make sure they don't have a history of seizures or a history of head injury that might actually induce seizures. Other drugs, imipenem with cilastatin, can also be associated with seizures. Isoniazid, and there's actually lots of other things with increasing seizures. Tramadol, which is a type of pain medication, can be associated with it. Metoclopramide can do it as well. And of course, withdrawal from benzodiazepines or alcohol, that can cause seizures as well. Next, we have tardive dyskinesia, associated primarily with the antipsychotics. You can also throw in there a metoclopramide as well. All right, it's time for that third game show. Let's get going. First one here, sulfonamides, amiodarone, tetracycline, that's going to be photosensitivity. Next, we have quinidine and quinine, that's going to be synchonism. Phenytoin and verapamil, think of gingival hyperplasia. Next, we have hydralazine, isoniazid, procainamide, think of lupus-like syndrome. Fluoroquinolones, you got to remember tendinitis. allopurinol, seizure drugs, antibiotics. Think of Stevens-Johnson syndrome. All right, and for our last group here, we have just some multi-organ type side effects. So if the first one is the disulfiram-like reaction, and that's going to include drugs like metronidazole, certain cephalosporins, procarbazine, which is an anti-cancer alkylating agent, first-generation sulfonylureas, which we really don't use anymore, so you're not going to run into that very often, and then disulfiram itself. Next, we have drugs with nephrotoxicity and neurotoxicity. That's going to include the aminoglycosides, cisplatin, and then the polymyxins. And then drugs that are both nephrotoxic and ototoxic are going to include the aminoglycosides, vancomycin, loop diuretics, and then cisplatin. And then anticholinergic side effects. More specifically, you might want to refer to these as antimuscarinic side effects, but we call them anticholinergic all the time. There are lots of different drugs that can have these side effects. Remember, these effects will dry you up. Atropine is sort of the prototype. That's a prototype anticholinergic drug. But there are other drugs that have this side effect. Think of the TCAs, the tricyclic antidepressants. The H1 blockers like diphenhydramine have this side effect. Low-potency neuroleptics like thyroidazine and chlorpromazine. So you really shouldn't give these drugs to patients that have delirium or dementia or any BPH or problems with urinating or with any ileus. All right, that brings us to the end of the lecture part. It's time for that end of session quiz. Let's go through this together. First question, what medication causes cardiotoxicity and maybe bone marrow suppression? So think of those anti-cancer drugs for bone marrow suppression, and the ones that cause cardiotoxicity are doxorubicin and daunorubicin. Next, an African American male that goes to Africa develops anemia after taking prophylactic medicine for primary disease prevention. What enzyme is this patient deficient in? So this is a G6PD deficiency. So what drugs cause hemolysis in that G6PD deficient patient? Remember, primaquine is one. The patient here most likely took primaquine, the malaria prophylaxis in this question, and the result of that taking of that medicine is going to be hemolysis. Next, 65-year-old male patient taking multiple medications presents with gynecomastia. Which meds could be responsible for this patient's gynecomastia? So the big ones that I see on test questions more often than not are going to be spironolactone and ketoconazole. But also remember the estrogens, cimetidine, chronic alcohol use, and marijuana. And don't forget those mnemonics. Some drugs cause awesome knockers or stacked. Next, a patient presents with tinnitus, dizziness, headache, and GI distress. What drug is causing these symptoms? So this presentation is synchonism, remember, and so this is either quinine or quinidine. Next, what medications are known for causing drug-induced lupus? So remember that mnemonic SHIP, and SHIP is going to stand for the sulfonamides, hydralazine, isoniazid, procainamide, and phenytoin. So these are the drugs that cause that antihistone antibody drug-induced lupus. All right, guys, that brings us to the end of our Pharm lecture. I hope you learned something. I'll see you next time.
Let's have a look at the warm-up review, which is just one question with multiple parts. It says, what information is communicated at each of the following nuclei? The nucleus solitarius receives sensory information, especially taste sensation from the tongue, as well as some baroreceptor and chemoreceptor information from the carotid sinus and the aortic bodies, and also sensation of gut distension. Then what about the nucleus ambiguus? We said the nucleus ambiguus deals with speech and swallowing. So this is motor innervation to the pharynx, the larynx, and the upper esophagus. And then last, the dorsal motor nucleus, which is misleading because this isn't really a motor nucleus. This sends autonomic information to the heart, the lungs, and the upper GI tract. All right, let's get started with the lecture.
Hello everyone and welcome to our Step 1 video on antidotes. So here's a true story. One time in residency, I had a very difficult patient. As I was examining him, I would ask him various questions about his medical history. He simply refused to answer any of my questions. Nothing I said could elicit a response. I came to the conclusion that he was suffering from some form of cognitive dysfunction. He could not even understand simple questions, so I sat him down. I tried to use very simple language to explain to him my findings that I thought that he needed to be evaluated by a neurologist or a psychiatrist. He then called me an idiot and told me that he was deaf. The moral of the story is that some people don't take bad news very well. All right, so let's move on to our antidotes. This video is all about antidotes. We're going to cover a long list of these, and then we'll basically review the entire lecture again in the end of session quiz. And just like in the previous video, I'm going to go through some clinical scenarios that might show up on the test. Now you'll notice that we're talking about antidotes here, which doesn't always mean the same thing as treatment. Sometimes you'll see a patient intoxicated or overdosed on a specific drug or toxin, and though an antidote exists, the more commonly used treatment might just be a supportive type thing. All right, so let's move on. So our first vignette here, a 27-year-old man presents to the emergency room with tachycardia, dilated pupils, agitation, and poor dental hygiene. Now the description here is a bit non-specific, you probably couldn't get just by that, but this could easily be a patient who has overdosed on methamphetamine. Now people who chronically use meth will often get what's called meth mouth. They lose their teeth due to xerostomia, poor oral hygiene, they usually drink a lot of sugary carbonated beverages, and also bruxism, the grinding of the teeth. So if you see a busted up mouth on a test question, think about meth. So what's the antidote? Well, you give ammonium chloride, which will act to acidify the urine, which will then help with clearance. Now, most of the time we treat the symptoms with benzodiazepines, antipsychotics, or maybe even antihypertensives to decrease elevated blood pressures. Next, we have acetaminophen. So this is found in nearly every household. So what's the toxic dose here? Well, at least 12 grams in a 24-hour period is going to be a toxic dose, and the recommended just maximum dose is about 4 grams in a 24-hour period. Now, the antidote for this is N-acetylcysteine. How does this work? Well, when the body receives too much acetaminophen, a toxic metabolite is produced, and it's called N-acetyl-P-benzoquinone amine. That's a mouthful, so we just say NAPQI. So too much NAPQI will damage hepatocytes. Now usually this metabolite is conjugated by glutathione. So the way this works is that N-acetylcysteine is going to work by replenishing that glutathione. Next, we have salicylates. So this is things like aspirin. So these patients are going to have things like nausea, vomiting, dizziness, and tinnitus. Now that tinnitus is a great clue on a question that a patient might have, that maybe they've taken too much aspirin. Now if you were to have a toxic overdose, what would you give? Well, you would give sodium bicarb, and that's going to alkalize the urine and trap that in the urine. Dialysis might also be helpful, but that obviously isn't an antidote. Next, we have acetylcholinesterase inhibitors, or often found in organophosphates. How would you treat that type of overdose? So remember, this is the drooling farmer scenario. So patients are going to have sweating, drooling, and diarrhea. So everything becomes leaky. So the antidote here is going to be pralidoxime. So how does that work? Well, it regenerates the acetylcholinesterase. And then to immediately help the symptoms, you would give atropine. Atropine is an anticholinergic that's going to fight all the actual symptoms regarding that organophosphate poisoning. So, super segue here, what if you have too much anticholinergic activity, too much antimuscarinic? So what's the antidote for this? Well, these patients will have too much dryness, so they're going to be dry as a bone, blind as a bat, bloated as a toad, those types of symptoms. The antidote here is going to be physostigmine. So remember that there are many medications that cause anticholinergic effects, such as H1 blockers, TCA, certain antipsychotics, and the prototype atropine. Next, we have beta blockers and calcium channel blockers. How would you treat an overdose of these? Well, you would expect to see bradycardia in these patients. Well, glucagon is the classic answer to this question, which really never made much sense to me. Now, the suspected mechanism is that glucagon increases cyclic AMP in the myocardium, which will bypass the beta-adrenergic second messenger system. So atropine is the other treatment that we have to think about. Atropine makes a lot more sense because it actually increases the heart rate. And then the next one is calcium. Calcium can also be used, which can help in contractility and myocardium conduction. So I want you to know all three of those things for beta blocker and non-dihydropyridine calcium channel blocker, or verapamil is an example of that overdose. So glucagon, calcium, and atropine, those can all be used to help increase that heart rate. Next, we have digitalis and digoxin. So arrhythmia is the most dangerous manifestation of a digitalis overdose. And as with many arrhythmias, you want to make sure that the potassium and the magnesium are optimized. So you might have to give some of that. If it's a very severe overdose, if you're having more arrhythmic type activity, you might have to give anti-dig fragments. But you won't see this done very often because it's not the most available medication in the world, and it's pretty expensive. Now, most of the time, supportive care is all that you need. Sometimes atropine can be given for any significant bradycardia. All right, let's do another vignette. A 3-year-old patient presents with 2 hours of abdominal pain, hematemesis, melena, and lethargy. So, and also this patient is suspected of eating a bottle of vitamins. So this is acute gastrointestinal phase of an iron poisoning. So iron poisoning can be quite severe, which can even lead to death, but that's not the only way to get an iron overload. Patients that receive frequent transfusions can also get too much iron as well. Now, patients that have beta thalassemia or sickle cell disease may be getting too much iron from multiple transfusions. So what's the antidote here? Well, the chelating agent here that we use is called deferoxamine. And we use the Fe in furoxamine to help you remember that you would treat an iron or an Fe overdose with deferoxamine. Next, we have lead poisoning. So lead poisoning can be difficult to catch sometimes. In children, you may see developmental delay or nonspecific GI symptoms. For severe lead intoxication, children should receive dimercaprol and calcium disodium edetate. So that's calcium EDTA. Now, for less severe intoxications, children can be given something called succimer. Penicillamine is a third-line agent only when the other drugs aren't tolerated. Now, this is different in adults. In adults, we tend to use succimer and that calcium EDTA as the first line. Next, we have mercury, arsenic, or gold. You can use dimercaprol or succimer. And there's a nice little hint for dimercaprol. If you think about gold as being a monetary unit and a dime as being a monetary unit, then dimercaprol is helpful then. Then you can also use the four-letter arrangement of merc, MERC for mercury as well, and that dimercaprol as well. So you can use that to help remember your dimercaprol for mercury overdose. Moving on to copper, arsenic, and gold, you can use penicillamine. So think about copper pennies, and also for copper overload, you would use penicillamine. So who gets copper overload? Remember, those are going to be our Wilson's disease patients. Also, don't forget those Kaiser-Fleischer rings in the eyes. Okay, so before we forget what we've learned so far, let's do a Lewis Notes matching game. All right, everyone, here we are talking about antidotes again here, and this is just to refresh our memories about all these things, get them really locked into our brains. Let's go through these. First, we have amphetamines, and amphetamines, we're going to be using ammonium chloride to counteract those. Next, we have acetaminophen. Acetaminophen you see pretty often in the ER. You're going to use N-acetylcysteine for that one. Salicylates, so a lot of aspirin overdoses, you might have a lot of ringing of the ears. In that case, you're going to be using a lot of sodium bicarb. So sodium bicarb is going to trap that in the urine. Acetylcholinesterase inhibitors, so these are going to be your drooling farmers. They get exposed to pesticides, so you're going to see that. And you can use a couple things here. The pralidoxime can be used to help replenish the supply, and then the atropine can help with the symptoms immediately. Next, we have the anticholinergic effects. You're going to use physostigmine in that situation. For the beta blockers and calcium channel blockers, you can use the triple therapy here. So you can use glucagon, calcium, and atropine for those right there. For digoxin, most of the time you're trying to just kind of get through that symptomatically. If they're in really bad shape and if your pharmacy has it in your ER, you can use those anti-dig fragments, but I don't see that used too often. Next, we have iron. You're going to use defuroxamine to treat that one. Lead, you can use a combination of things. You could use dimercaprol. You could also use calcium EDTA or succimer. So you can kind of use that one right there. You could put dimercaprol in that situation as well. Mercury, arsenic, gold. That's going to be dimercaprol that you're going to put on right there. And then for copper, arsenic, gold, think of copper as those pennies, so you can use penicillamine in that situation. All right, so I hope you got all those and know all your antidotes, and I think you'll be in good shape for the test. Okay, so we're back, and let's do another vignette. So a 53-year-old homeless man presents with confusion, headache, vertigo, and flu-like symptoms. On exam, he has very red-appearing lips. Okay, so not many things are going to cause those red-appearing, or sometimes referred to as the cherry red lips. So this is carbon monoxide poisoning. How did this homeless man get carbon monoxide poisoning? Well, we often think of house fires or car exhaust, but don't forget about kerosene lamps, heaters, or even stoves. So maybe he was trying to keep warm by sitting next to a kerosene heater. Now, how do we treat this? Well, the answer is 100% oxygen to try to displace that carbon monoxide, and then you can even use like hyperbaric oxygen if it's available. All right, so next is methemoglobin. So remember that methemoglobin leads to a decreased ability of the red blood cells to release oxygen to the tissues. Now the antidote here is methylene blue, and methylene blue restores the iron in hemoglobin to its normal reduced oxygen carrying state. The other thing that you might see is vitamin C being used, and vitamin C can be helpful, but it's not that helpful in acute toxicity. Next, we have cyanide toxicity. So cyanide acts by inhibiting cytochrome C oxidase. So cells are then unable to use oxygen. So who gets cyanide toxicity? Well, if you've been in a house fire, you might get it. Poison can also occur by inhalation of fumes from burning polyurethane or vinyl, but it can also be found in simple things like tobacco smoke, almonds, apple and orange seeds, and bamboo shoots. Now, those aren't going to kill you right away, but it is a chronic exposure. The other way is if you receive an excess of sodium nitroprusside. So how do we treat cyanide toxicity? Well, first line is a combination of hydroxycobalamin and thiosulfate. Hydroxycobalamin is just a form of vitamin B12, which can actually bind to cyanide and form the harmless cyanocobalamin. Now, another treatment option are the nitrites. So nitrite will convert hemoglobin to methemoglobin, and cyanide loves to bind to methemoglobin. Of course, if you have, you might induce too much methemoglobin, so you get methemoglobinemia. So you'd have to give what? Methylene blue. So you start with that combo of hydroxycobalamin and thiosulfate, and if that doesn't work or if it's unavailable, then you'd go with nitrites. Next, we're moving on to methanol or ethylene glycol. So this is found in antifreeze. It has kind of a sweet taste. So unfortunately, children may drink this thinking it's kind of juice. Fomepizole is your drug of choice here. So how does it work? Well, it inhibits alcohol dehydrogenase. And if you don't have fomepizole, you can actually just use ethanol to compete for the active site, or you can actually use dialysis as well. All right, let's do another vignette. A 22-year-old man is brought into the ER unresponsive. In addition to the depressed mental state, he has decreased respiratory rate and pinpoint pupils. What's the diagnosis? Well, this is likely an opioid overdose, and the best predictor of an opioid poisoning is a respiratory rate less than 12. But on a test question, be on the lookout for those meiotic pupils. Now, the antidote here is going to be naloxone or naltrexone. Naloxone is used more often in the acute setting, but you also need to remember that it has a short half-life. So the effect is short, and so you need to repeat the dose, or the patient will wake up and then fall right back into an obtunded state half an hour later or some other time later. Now, drug addicts actually get pretty pissed because when you give them the naloxone in the ER because you've wasted their high, so they kind of wake up all mad like, what'd you do? All right, next we're moving on to benzodiazepine. So benzodiazepine overdose is going to be treated with flumazenil. But be careful with this because rapid reversal of benzodiazepine toxicity can lead to seizures. So most of the time, supportive care is the actual treatment. Next, we have TCA overdose, so tricyclic antidepressants. We're using these less and less now, but if you get an overdose of this, think of sodium bicarb. This is your treatment of choice, just like we saw with the salicylate overdoses. Next, we have heparin. So heparin overdose is treated with protamine. So the way I think about this is that you think about the H in heparin, and I think about it as the H plus molecule or a proton. So you use protamine to treat that proton, which is heparin. And that's kind of a loose association, but that's a good way to remember it. Next, we have warfarin overdose. So use vitamin K here. So warfarin works by inhibiting the vitamin K clotting factors. But what if you need to reverse the anticoagulation very quickly? Will vitamin K do that? No, vitamin K works very slowly over a matter of days. To quickly reverse warfarin, you're going to have to give fresh frozen plasma. So fresh frozen plasma has all the clotting factors still in it. It's going to take 3 to 5 days for those clotting factors to come back with that vitamin K administration. Next, we have TPA, streptokinase, urokinase. These are the clot busters. They can save lives of patients who are having strokes or heart attacks, but they can also over-anticoagulate patients as well. And the antidote here is going to be aminocaproic acid. Next, we have theophylline. So theophylline, we use that in a lot of our asthmatic patients, typically causes an overdose tachycardia. So theophylline is, with that tachycardia, you're going to want to use something like a beta blocker to counteract that fast heart rate. All right, that's the end of the lecture part. It's time for that end of session quiz. Let's go through those answers together. All right, let's get going here. This is a very long question. It's basically going through all of the answers that we went through today. So what are the antidotes to the following toxins? So first, acetaminophen. The answer was N-acetylcysteine. Next, salicylates. So this is aspirin. Remember, aspirin is a weak acid, so to trap that acid in the urine, you're going to need an alkalizing agent to alkalize that urine. So we give sodium bicarb to alkalize that urine. And then maybe dialysis is also effective in getting rid of those things as well if it's too bad. Amphetamines, these are weak bases, so you're going to acidify the urine with ammonium chloride. Anticholinesterase, organophosphates, the reversal agents are atropine and pralidoxime. Pralidoxime is going to regenerate that acetylcholinesterase. Antimuscarinic, anticholinergic agents, remember the prototype antimuscarinic is atropine, and we fix an atropine overdose with physostigmine. Next we have digoxin, so you're going to stop that digoxin. You're going to normalize your potassium and your magnesium. If there's bradycardia, you might have to give atropine, that's the one, to increase the heart rate, maybe a cardiac pacemaker if it's really bad. But the actual antidote here is going to be anti-digoxin antibody fragments. Next we have iron. So the treatment for iron toxicity is deferoxamine. So remember that the chemical symbol for iron is that Fe, so that's how you remember deferoxamine. Next we have lead. The antidote would be EDTA or Succimer or dimercaprol. Arsenic, mercury, gold, you can use dimercaprol or Succimer. The dimercaprol is pretty easy to remember because remember it has merc in it, so for mercury toxicity. And then dime might also help you remember money for like gold. Next one is copper, arsenic, and gold. So penicillamine for copper and gold. Remember, pennies are made out of copper, so we treat copper toxicity with penicillamine. Next, we have cyanide toxicity. So to treat it, you might give the nitrites, but more often you're going to get that hydroxycobalamin with ethyl sulfate. Next, we have methemoglobin. So your reversal agent is going to be methylene blue, and then maybe a little vitamin C on the side as well. Carbon monoxide binds to hemoglobin and competes with oxygen for that binding site. So treat with 100% oxygen and maybe hyperbaric oxygen if you have it. Methanol or ethylene glycol, which is antifreeze, you can have a few options here. You can give ethanol to competitively inhibit that metabolism of these, or you can do hemodialysis. The drug of choice, the antidote, is going to be fomepizole. Next, we have the opioids. What is the reversal agent here? It's going to be naloxone more often or naltrexone. Antidote for benzodiazepines is going to be flumazenil. Tricyclic antidepressants, you're going to alkalize that urine with sodium bicarbonate to help get rid of these. For heparin, it's going to be protamine. For warfarin, it's going to interfere with your liver's ability to make that vitamin K dependent coagulation factors. So the reversal agent is just vitamin K, but it's going to take a lot of time for that vitamin K to start working. So if you need to immediately reverse warfarin, then you just need to give fresh frozen plasma. That's going to replace all of those coagulation factors that the patient is deficient in. Next, we have TPA and streptokinase. The reversal agent is going to be aminocaproic acid. And then finally here, theophylline. Theophylline has that poor therapeutic index. It can be very cardiotoxic, and that's treated with beta blockers. All right, guys, that brings us to the end of our intersession quiz. I hope you learned something. I'll see you next time.